Hi everyone, welcome. Welcome to the rapid revision of pharmacology, the much awaited session. So many of you were messaging me for this. So finally the day has come. Now, before we begin this session, let me give you an outline what I'm going to do in this. Okay. So number one, I'm going to give you a quick review of the most important topics that are usually asked in the examination. That is going to be the rapid revision part. Now for the extra edge, after I finish that session, right, that is the rapid revision, I'm going to discuss the MCQs that were asked in the year 2025, 2024 and 2023, especially when it comes to the FMG, as well as for the extra edge, we are also going to see that for NEET PG as well as INI set. Now, those who just want to do the rapid revision, once you're done with this section, I'm going to tell you that this part is done. You can, sign off. But if you are interested, definitely, which can be beneficial for you in my opinion, because majority questions will get picked up from the previous year topics only. So that is the purpose. I am making sure that you guys do that as well. So maybe not today, if you're not having that energy to do that MCQ session today, you can do that later as well. But this will be one full session that I'm going to continue with. Okay. So minimum, my advice to all the people who's taking this FMG exam, do make sure you listen to my FMG discussion as well as the NEET PG question discussion. INI set is optional. If you're watching it later on, you may skip that part and do it. Now to make it much more, better for you guys, I have divided those MCQs based on chapter wise. All right. So that means you will get an idea in each chapter where are they targeting more. Is that understood? So I believe like all of you will take this seriously and get the most benefit out of it. Anyway, so let us get going. Let's get started. Now, first thing, we are here at this picture. Now you can see there is brain and then there is spinal cord. Okay. Now what do you need to know here is there are nerves coming out of the brain called cranial nerves, and the cranial nerves, which are numbers 3, 7, 9, 10, they happen to run your parasympathetic system. So as you can see in the picture over here, there is a neurotransmitter called acetylcholine in the parasympathetic system. That is the reason parasympathetic is also known as cholinergic system, because of presence of acetylcholine. Now when this acetylcholine increases, let's say, this will work on receptors called muscarinic receptor, which we will represent by the capital M, and this is going to increase parasympathetic functions. As you know, in pharmacology, we have two types of drugs, one that increase, one that reduce. The drugs that increase are called agonist, and the drugs that will reduce are called blockers or antagonist. Okay. So muscarinic agonist means they will increase parasympathetic, muscarinic blockers means they will reduce parasympathetic. Same goes for sympathetic system. So sympathetic system is coming out of the nerves called thoracolumbar. That means from thoracic nerves till the lumbar nerves. So thoracolumbar is this. So you can see the neurotransmitter in this system is noradrenaline. Hence this system is called adrenergic system. Obviously, there are some receptors on which this guy works called alpha beta, and this is going to increase sympathetic functions. Okay. Last and the final. So we got this parasympathetic system. This is parasympathetic. This is sympathetic. And we got somebody called somatic nervous system, which deals with skeletal muscles. Again, in this topic also, the neurotransmitter is acetylcholine. Only difference is the receptor, instead of muscarinic, which was present in parasympathetic, now you have nicotinic receptor, NM receptor. And this stimulation will induce skeletal muscle contraction. Now that we have said this, we can actually proceed ahead now. See, whenever acetylcholine gets made, as I told you, it can work on two types of receptors, one called muscarinic, another called nicotinic. I just told you nicotinic receptor stimulation will cause skeletal muscle contraction. So same thing will happen here as well, skeletal muscle contraction. So basically acetylcholine causes muscle contraction. And when it stimulates the muscarinic receptor, you all know parasympathetic functions will increase. And usually the way I teach you in classes also, you must remember the word dumbbells. That means when parasympathetic system is stimulated, all these functions will happen called dumbbells. And if you have a drug who blocks this muscarinic receptor, all these functions will reduce. So to keep it simple in the head, we memorize opposite of dumbbells. Are you all understanding that? Now, what are the drugs that we are going to discuss in this topic coming up shortly? There will be one drug who comes and stimulates muscarinic receptor. This will increase parasympathetic functions. So basically, those are the drugs having chol in the name. Okay, bethanechol, pilocarpine, those kind of drugs. Next, we will have a drug who will instead block this receptor. If you block this receptor, all these functions will be blocked. So these drugs are going to have trope in the name, atropine-like drugs. They will reduce all these functions. Okay. Next is, if you happen to block this receptor, you will get skeletal muscle relaxation. Yes or no? So these drugs are called skeletal muscle relaxants. Drugs like Curare, Curarine, Curium, etc. Okay. So basically, this is a rough idea I'm giving you in advance before we actually move into the drugs. Last and the final, acetylcholine can break down by one enzyme called acetylcholine esterase. So if you happen to block this enzyme, logically you're going to have more acetylcholine. When you have more acetylcholine, both the receptors will get stimulated. These drugs are called stigmine medicines. Okay, simply put, they are called as stigmines. So what do stigmines do? Stigmines will work on this receptor as well as this receptor. So you will get more parasympathetic functions like dumbbells as well as skeletal muscle contraction. Okay, so that is the logic that we had to learn over here. Now that we have learned this, let's move on into the drugs. Okay, now you can probably see we are seeing some name here called indirect agonists. So what are these drugs? What exactly should we do? Let's try and understand this logic. Okay. Now, my friends, first thing, okay, indirect agonist, if you see the word, how do these drugs work is they block acetylcholine esterase enzyme. When you block this enzyme, what will happen? There will be increase in the level of acetylcholine, and this increase, I just told you, can bring more parasympathetic functions and more of skeletal muscle contractions. Okay. Now, what are the drugs that are coming in this list? See, there is a disease called Alzheimer where you have less acetylcholine in your brain. So what do you want to do in the treatment? Increase acetylcholine. So that's why these drugs are used. The best medicine from the given list is donepezil. Okay. Next, rivastigmine from this list is available in the form of a patch. Okay. Next is tacrine. Tacrine is not used anymore. T for toxic. It is a hepatotoxic drug. We don't use that anymore. Next, I just told you, when you block acetylcholine esterase enzyme, you have more acetylcholine. More acetylcholine means more parasympathetic functions and more muscle contraction, correct? Since these drugs can increase parasympathetic functions, they can be used in those diseases where you have less parasympathetic. So there are 3 diseases where you have less parasympathetic. What are they? You can remember by the word BAT. Belladonna, atropine, datura, 3 places where parasympathetic becomes less. What is the antidote to be given? The answer is physostigmine. Okay. Now that this is over, let us move on. Third thing, I told you the drugs called stigmines can cause muscle contraction. So they should be used in those diseases where muscles are excessively relaxed, example myasthenia. Now by multiple subjects, I'm sure you guys have already learned this. Myasthenia is a disease presenting with muscle relaxation. So what can you do in this? First, we can do a diagnosis of this myasthenia by a drug called edrophonium. Edrophonium is a short-acting drug, and the name of the test we are doing here is called tensilon test. Okay. So what happens? The patient comes with ptosis because the muscles are relaxed. Okay. Now, since we have said this, this is ptosis. What happens, sir? Muscles were relaxed, but now the muscles will start contracting when you give a drug like edrophonium. Patient's eye opens up, patient is feeling better. See, understand the simple logic? If you give a drug of myasthenia gravis topic to somebody and they start feeling better, what does that mean to you? That means they have myasthenia, no? Because they have myasthenia, they're feeling better by the drugs of myasthenia. So, short-acting drug of myasthenia topic is edrophonium. If you give this drug and the patient feels better, simple diagnosis, patient has myasthenia gravis. If the patient feels better, put them on long-acting drug. Who's the long-acting drug in this? Pyridostigmine. So, pyridostigmine is used in the treatment of myasthenia. We can use neo also. Neostigmine can also be used, but the better drug is this one, pyrido. Okay. Now, next we can move on. There are some poisons called organophosphates and carbamates. Now, what do you need to know? Same story. These guys, example, usually what they will ask you is organophosphate, in short called as OPs. So what do these OPs do? These OPs are going to block this enzyme called acetylcholine esterase. Because of this, now you will have excessively high levels of acetylcholine. See, we are talking poisons, they will be doing too much in the body. Now, when you have this excess acetylcholine, as usual, it will work on muscarinic receptor and nicotinic receptor. Okay, both the receptors are stimulated. So when muscarinic is stimulated, nothing changes. Remember, I told you when muscarinic is stimulated, everything what we wrote here will happen. Okay, so basically what is happening here is dumbbells is happening. So when patient comes with dumbbells, understand it is a OP poisoning case. Now who's a OP poisoning case? Farmer. Usually they will mention the word farmer because these are pesticides or insecticides. Okay, I hope you guys understand this. This is pesticide or insecticide. Now that this part is done, ask yourself one question. What is the problem in, this topic? Too much of parasympathetic. So I should give you one medicine that blocks this muscarinic receptor so that I can control all the symptoms. The drug that blocks muscarinic receptor only, it is called as atropine. So basically the logic is, since atropine works only on muscarinic receptor, it can only control muscarinic feature, it cannot control nicotinic features. That's why this muscle relaxation will still stay despite giving atropine. Okay. Now in OP poisoning, just a mnemonic, this is the exam. As of now, quick answer, OP mein we can add one more drugs called oximes. Oximes are drugs that are added in this. Okay. Now oximes hote kya hai, etc. That I can't go into everything right now. Just an idea, done. Now this is a very high yield table that all of you must remember, sir. This is about the toxicities, their antidotes, their presentations, because 1 or 2 questions will show up from here. Just now we did something. Organophosphate means they block acetylcholine esterase. You will have too much of parasympathetic activity. This is excess parasympathetic action. Datura is opposite. Datura means they are blocking muscarinic receptor. So they will have decreased parasympathetic. They are exactly opposite. So one guy will present with dumbbells. One guy will oppose dumbbells. Opposite of dumbbells. Correct? Now if you understood this, since the patient is coming with too much of parasympathetic, What do I do in the treatment? I will reduce that by giving atropine, which we just learnt. Okay. Next, if you look at Datura, Datura is nothing but less parasympathetic. Since it is less parasympathetic, we should increase it back by giving the drug called physostigmine, which we learnt 5 minutes back. Okay, now that this is it, cocaine is increasing sympathetic activity because cocaine, what does it do? It increases noradrenaline. Okay, it's increasing noradrenaline. That's why it increases sympathetic functions. It is mostly symptomatic treatment. There is no specific antidote for this guy. Okay, no antidote for cocaine. Next, opioid. Okay, next is opioid. So when you talk about opioid drugs stimulate receptor called mu receptor. The drugs which are mainly painkillers, etc., they come in the opioid category like morphine, etc. So this drugs, heroin, morphine, etc., if you do opioids, please remember the antidote, very routinely asked MCQs, it is naloxone. IV naloxone is the antidote of choice. So you have to later, look at this chart that I've given here. Quickly learn to diagnose opioid. Both come with meiosis. When you have opposite of organophosphate, that is bad, datura, belladonna, atropine, they come with mydriasis, as well as cocaine also comes with mydriasis. That is the starting point. Next, you should look at some other features and learn to recognize which one is which. Okay, so we have done this table. Now that we have done this, next part is anticholinergics. The word is anticholinergic, means they are the drugs that will be opposing parasympathetic, anti-parasympathetic drugs. So first drug is Botox. How does Botox work? Very important. Botox blocks the release of acetylcholine. Okay, it blocks the release of acetylcholine. And if you block the release of acetylcholine, what will happen is muscles will relax. Muscles will relax. That's what Botox will do. Since it is relaxing the muscles, it can treat some kind of a contraction. Example, blepharospasm, wrinkles, achalasia, cardia, etc. That's it. So important, make sure you know the mechanism of Botox. Next is drugs directly working on the receptor, muscarinic blockers. Now, if you talk about muscarinic blockers, you must know, generally speaking, they have tropes in the name. Ipratropium as a bronchodilator, atropine as a drug used in the heart, etc., etc. Okay. Now, when it comes to urinary system, first ask yourself, if you are blocking parasympathetic system, don't you think logically urination will reduce? Only if you know dumbbells perfectly, this all will make sense to you. Now is the exam time. I hope you remember those basics. So I am saying when you block parasympathetic, what will happen? Urination will reduce. Since these drugs reduce urination, they are used for overactive bladder. Okay, incontinence, etc. What is the mnemonic that you got to remember here? Soft detrusor. Okay, SOFT, soft detrusor. Now from this soft detrusor, one drug does not cross blood-brain barrier, that is trospium. Since it doesn't cross blood-brain barrier, this will be the drug safe in Alzheimer's. Okay, it is a medicine that is going to be proving to be safe in Alzheimer's. Okay, next, antiemetic, very popular drug. Many of you already know, scopolamine or hyoscine. It is used in preventing the motion sickness. Basically, it's an antiemetic, right? It's an antiemetic. How will you get antiemetic effect? If you block dumbbells, E for emesis was happening now, so antiemetic effect will come. This is all it is. Now coming to something called sympathomimetic drugs. Now, what is the story of sympathomimetics? As the name says, these are the drugs that increase sympathetic activity. Adrenaline. Now, you must remember, adrenaline is the drug of choice in anaphylactic shock. Preferred route is intramuscular, given usually on the thigh. If this doesn't work, you may go for subcutaneous. Next, what is the concentration generally used is? It's called 1:1000. Now in the class I have explained to you the whole translation. I'll simply write what does 1:1000 mean here. It means 1 mg adrenaline is present in 1 ml of solution. That is what it translates to. Same way, you must remember IV route is more effective in the heart problems. That's why in cardiac arrest, etc., I'll give you IV route. And IV being very strong, you cannot give it directly in 1:1000 concentration. You need to dilute it and give. So what is the dilution? 1 mg adrenaline is going to be present in 10 ml of solution. Okay, it's going to be present in 10 ml of solution. Next, now that you have seen this, what is the other thing you need to know is, this guy shows something called as vasomotor reversal of Dale or epinephrine reversal. It simply means when you give adrenaline along with alpha blocker, you will get less BP called hypotension. This happens due to beta 2 receptor. I'll explain that to you in simple language what that is. See, when you give the drug as a adrenaline, you know what adrenaline does? It works on a receptor called alpha 1 which causes vasoconstriction. And it works on a receptor called beta 2 which causes vasodilation. So now, if I give you adrenaline, by this logic, BP should be neutral only, na? One receptor increases, one receptor decreases. It's not like that. Alphas are more dominant. So net effect, what happens? BP increases when you give adrenaline because who's more stronger? Alphas. Because of alpha, BP increases. Now there was a scientist who did one experiment called vasomotor reversal of Dale. So what exactly is this? What this person did is, along with giving adrenaline, he also gave one more drug called alpha blocker. Alpha blocker. So alpha blocker if you give, now you can notice alpha receptor is blocked, only beta is working. And what will beta do? Vasodilation, reducing BP. So when you give adrenaline along with alpha blocker, what is happening? BP reduces. So this is the experiment called vasomotor reversal of Dale. Okay. Now, since this is done, we can move to the next aspect. Okay. If we see this graph, okay, if we see this graph, what are we learning from this? Okay. Now, if we see this, it is showing two things in this graph. One is blood pressure and another is heart rate. Now, this is a thing I want you to memorize for the last minute as of now. Okay. Let's check this. Drug A, B, and C, who is it? Okay. Now, sir, if you notice, when you're giving all the three drugs, see, this peaks represent things are going up. So if you see here, from the baseline 120, the BP is going up. Are you noticing that? This is the baseline now. BP is going up. So this drug A, increases BP. But what does it do? It reduces heart rate. Okay. Second drug, if you see, it increases BP, but it also increases heart rate. Third drug, okay, it is kind of reducing the BP, but what does it do? It increases heart rate. So who are these drugs? Let's remember this. When the heart rate goes down and the BP goes up, you need to remember this drug is noradrenaline. Okay, this guy is noradrenaline. Next is drug B. What is drug B? Okay, adrenaline. What is adrenaline story? Heart rate also increases, BP also increases. Third drug is somebody called isoprenaline. Okay, isoprenaline. What does isoprenaline do? It will increase heart rate quite a lot and it reduces the heart rate, or sometimes it is same only. All right. So that is the logic right here. ये एग्जाम के लिए याद रखना है, very important as of now. Okay. Next, moving further, indirectly increasing sympathomimetics. Now, what is indirectly increasing sympathomimetics? Basically, they also increase sympathetic activity by some other mechanisms. Okay, one is cocaine. Now, you must remember, cocaine is having caine in the name. It is actually a local anesthetic. Now, this is the only local anesthetic which causes vasoconstriction because it increases sympathetic activity. Other caines, they are vasodilators. Okay, other caines are vasodilators. Now that we have gotten this idea, next imagine there is a toxicity of local anesthetics. What do? You give something called 20% intralipid. Okay, intralipid. So what does it do? What is this antidote? See, basically it acts like a fat sponge. Okay, it acts like a fat sponge that can suck up the fat molecules. Local anesthetics are lipophilic. Lipophilic means they like fat. So when they see the fat sponge, what will happen? They get sucked here. So there is this substance called 20% intralipid working like a fat sponge. Imagine the drugs called local anesthetics are like fats, lipophilic drugs. It absorbs them. Done. That is the antidote called 20% intralipid. Now that this is done, release enhancers, as the name says, they increase the release of sympathetic neurotransmitters. Always remember, when sympathetic activity increases, BP generally increases. That's why you may get hypertension. There's something called cheese reaction, right? Tyramine is a substance present in wine or cheese. Wine or cheese. And if you consume these substances, you may get cheese reaction. This reaction especially is seen in people taking MAO inhibitors, which are antidepressants. Example, phenelzine. Okay, example is phenelzine. This is known as cheese reaction. Next is a famous medicine called methylphenidate. It is the drug of choice for ADHD, attention deficit. Now you must remember, neurotransmitters from sympathetic system, they can increase your focus ability, and that can help you with a person having attention deficit. Okay. Next is a drug called modafinil. Modafinil is a medicine that is used in narcolepsy. Now what is narcolepsy? Narcolepsy means excessive sleepiness. I just told you, sympathetic activity neurotransmitters, they can increase your focus. When you're having focus, you will not be sleepy. That's why this drug is used. See, when is it awkward to sleep? Nighttime or daytime? Daytime. If you're sleeping during daytime, that's a problem. So let's remember, this drug is used for daytime sleepiness, modafinil. All right, this drug will be used for the daytime sleepiness. Agree? Now, guys, please let me know now. Are we back? These things can happen once or twice. We may get a lag, not in our control. Check this and let me know. Okay, nothing. We didn't miss out on anything. Just one or two small things I said. Now let's get back. Check this out. I was telling you there is a receptor called beta-2 receptor. Just remember, we have two lungs. So beta-2 is mainly for asthma. How do you give the drugs of asthma? Generally by inhalational route. Now keep in mind, one drug can be given subcutaneous in this, called terbutaline. Terbutaline. All right. So we have all these drugs like salbutamol, salmeterol, etc. in this list. Okay. Now in this, I would request you guys sit and memorize the side effects of beta-2 agonist. They are very important for us. Side effects of beta-2 agonist, like tremors. That is the physical side effect we see with SABA-LABA. Okay. They reduce the potassium levels, basically hypokalemia, and they cause increase in the sugar levels called hyperglycemia. All right. So this is the simple logic right here, that this is the topic right now. Next is another very high yield topic called sympatholytics. As the name says, lysis means breaking down. These are the medicines that will reduce parasympathetic functions. Okay, they will reduce parasympathetic functions. Who do you have in the topic called alpha blockers? Here we got these guys known as alpha blockers, non-selective. First name, very big name, called phenoxybenzamine. So big name we got, will remember it's used in a big situation called pheochromocytoma. So what is the logic behind this, what we are doing? First, you must remember alpha blockers, they will reduce BP. That means these drugs are used in the treatment of severe type of hypertensions. Not just any hypertension, severe hypertension. So phenoxybenzamine is used in pheochromocytoma. Always remember this. Okay. Next, there is the drug called phentolamine. It's also used in severe hypertension, but which one? Cheese reaction. Cheese reaction. So cheese reaction we just learned, it happens due to tyramine. Remember we said it happens due to tyramine. And another severe hypertension that happens due to one drug called clonidine. Okay. So clonidine has this very special side effect we always have emphasized called rebound hypertension. So whenever there is severe hypertension, please remember we can treat it by these medicines called non-selective alpha blockers. Cool. Next is alpha 1 blockers. Okay, alpha 1 blockers. What are these alpha 1 blockers? The idea is simply this. So these drugs, they're used in the treatment of hypertension with BPH. So they have one extra effect now. They are not only used for hypertension topic, they are used for BPH also. Now, as you know, this is just a rapid revision. It's not a full class where I can unfortunately explain you each and everything. So hypertension plus BPH. So these drugs you got to remember as Zosyn type of drugs. Example mainly Prazosin. So Prazosin is that drug. Please remember this mnemonic here. Prazosin has that PR. Na? We can remember that PR for it's used for pressure, that is hypertension, plus prostate, that is called BPH. So this is the medicine used for pressure as well as prostate. So that is the simple logic, the way you can remember this. Okay. Now the logic is this, sir. Since these type of alpha blockers, they reduce BP, na? They reduce BP, that's why they're used in hypertension. That's why their side effect, because they reduce BP, is hypotension. Okay, they can all cause hypotension. Cool. Last drug is selective alpha 1A blocker. This is the drug used only in treatment of BPH. It's not used in any other disease. It's used only in BPH. These are drugs like tamsulosin or sildosin. And also you must remember one more thing, like if you want to reduce the size of prostate, then there is a drug that we will be studying later called finasteride. So finasteride is to reduce the size of prostate. Cool. So what did we learn here? Three types of alpha blocker. First, to reduce BP, hence they can be used in hypertension. This second one has extra effect, can also be used for prostate problem. And the last one is only in the BPH. Okay. Now, since we have talked about this, consider it like this. There are two countries. One language is spoken here, another language is spoken here. The people near the border can speak both. So the one in middle called alpha 1 blocker, they can be used in BPH also, they can be used in hypertension also. Cool. All right. So this is the logic right here. Next, we are diving into something called cardiovascular system. Now, what do you have in this chapter? The drugs called antihypertensives. So when you talk about antihypertensives, they work by different mechanisms. Vasodilation can reduce BP. If you block RAS, that can reduce BP, and so forth. So there are different types of things that can happen here. Now simply what I would want all of you to know is this. Drugs acting on RAS, the top drugs are known as, see, first of all, what is the second word in RAS? Angiotensin. So there are two drugs working on angiotensin, one called ACE inhibitor, second called ARBs. The drugs we famously know as prils and sartans. Prils and sartans. Okay. Now, since we have said this prils and sartan, remember that these drugs are generally considered to be nephroprotective drugs. Hence, for this reason, they are useful in diabetic nephropathy or CKD. Okay. Now that this part is done, we can move on to the next thing, that is losartan. Losartan is a special drug having extra activity. What does it do? It can reduce the platelet activity, it can lower platelet activity, and it can lower the uric acid in the body. It is reducing the uric acid in the body. So since it's lowering uric acid, it can be used in gout also, right? Now remember it like this: losartan lowers uric acid, lowers platelets. Easy way to remember this. Okay. Next, telmisartan, the famous drug. Tell me what is the use of, special use of this guy. If I ask you, you should say, sir, it's useful in diabetes mellitus. DM, diabetes mellitus. Got it? Next comes side effects. ACE inhibitors, they increase bradykinin, hence they will cause dry cough, and this side effect is not noticed with sartans. Okay, that is the only difference. The top drugs of hypertension called ACEs or ARBs are avoided in pregnancy, and they are avoided in something called bilateral renal artery stenosis. Bilateral renal artery stenosis. Okay, so I hope all of you understood this. Next, spironolactone. This is also a topic called RAS blocker drug. Last topic is aldosterone. See, our intention is to block RAS. If you block RAS, BP decreases. Angiotensin blockers were ACEs and ARBs. Aldosterone blocker is spironolactone. Okay, aldosterone blocker is spironolactone. So this drug, it is used in the treatment of resistant hypertension. What is resistant hypertension? The definition is given: when 3 antihypertensives are not effective in controlling BP, the fourth drug you will add is spironolactone. Okay, so in resistant hypertension, what do? Treatment is add spironolactone. That is the fourth drug. The fourth drug is spironolactone. Okay, next. After this, imagine a person is having only one disease called as hypertension. The patient is not having any other disease, patient is having only hypertension. How do you proceed in the treatment? 3 drugs. ACD. Okay, ACD. ACEs are more better compared to ARBs. ACD. If the patient is young, that is less than 55, go for ACEs or ARBs. If the patient is greater than 55 years of age, then you go for calcium channel blocker or diuretics like thiazides. Now, go through this table later on. Hypertension with comorbidity, meaning if you have some other disease, use such a medicine which can benefit both. Okay, are you understanding? What do? If you are having only blood pressure, choose between A, C, D. And how do you proceed further? By looking at the age. What if patient apart from BP has some other disease? Choose the drug which can not only control BP but the second disease also. And that list is given that you have to sit and memorize later. Okay. Now, this is the topic called diuretics. So, what do diuretics basically do? Diuretics work in this part called nephron, and they will make you lose the sodium and water. Along with sodium and water, a lot of times you're also going to lose potassium as well. So almost diuretics make you lose potassium except for one drug. Because it makes you save potassium, those drugs working in the collecting duct are called potassium sparing. So let's repeat this. All diuretics lose sodium. That's how they are diuretics. They make you lose water also. Almost diuretics make you lose potassium except one called potassium sparing. The name itself is shouting, I save potassium. Okay. The way to remember, you want potassium to stay. We say potassium, please have a seat. That's just an easy way, right? Potassium, please have a seat. That's how you're going to ask the potassium to stay. Okay, boss. Now, what do you do? First of all, you have to go through this chart, and what do you read from this chart? Which part of the nephron, which diuretic works. For example, in the PCT, we got carbonic anhydrase inhibitor, example acetazolamide. Okay. Next, moving on. Loop of Henle, we got loop diuretics, logically. Furosemide, most important example. Next is DCT. If you talk about DCT, we got thiazides. All right. Collecting duct, I already told you, potassium sparing diuretics, which are of two types, aldosterone blockers and ENaC blockers. Aldosterone blockers and ENaC blockers. Last thing, there is a diuretic that works in two places, that is PCT also, loop of Henle also. It is known as osmotic diuretic called mannitol. Once we have learned which part of nephron which drugs work, if you can memorize, please know the channels on which they work. Okay. Anyway, this will strengthen your physiology questions if they ask physiology also. Are you understanding that? This channels, you must know which drug is working on which channel here. Okay. Now the uses of each of them. Famous drug, acetazolamide is used mainly for mountain sickness. At least for the exam point of view, you should know mountain sickness key drug of choice is acetazolamide. Next is pulmonary edema. The drug of choice is furosemide, loop diuretic. Okay. Next is, if you move in the collecting duct, we have two types of drugs. Aldosterone blockers like spironolactone are drug of choice for Conn's syndrome. What is Conn's syndrome? Excess aldosterone. So if your body is having too much aldosterone, what do you want to do in the patient? Block that. So that's why spironolactone is the drug of choice for Conn's. The same drug also happens to be the drug of choice for cirrhotic edema. Cirrhotic edema. Clear? And it is also the drug of choice for resistant hypertension. So basically, the uses of this drug called spironolactone, I am highlighting here. This is drug of choice for all these three. Whereas a drug called amiloride, this amiloride is useful for lithium-induced diabetes insipidus, Liddle syndrome. These are the places where there is too much ENaC. क्या problem होता है यहाँ पे? There is too much of ENaC. Since there is excess ENaC activity, our aim is to block the ENaC by a drug called amiloride. Okay. Last and the final, very famous, there is this drug called mannitol, the drug of choice for cerebral edema. Cerebral edema, this is the drug of choice. Okay. So diuretic, one question expected from this chart, right? Next is a topic exactly opposite. It is called anti-diuretic hormone, right? The next one in the list is anti-diuretic hormone, ADH. Now there are two drugs in this that I want you to know. Vasopressin. Vasopressin, if you talk about vasopressin, the name is saying vaso means vessel, press means constrict. So vasopressin, this is the guy that works on two receptors. One called V1 receptor, one called V2 receptor. Each of them have a different function. V1 receptor vasoconstricts. V2 receptor does ADH function. That means it will save water. It will save water. All right. So now what I'm saying, check this out. Natural vasopressin works on both the receptor. It is non-selective. It works on V1 also, V2 also. But right now the drugs we are speaking, they are exclusive drugs. Terlipressin works only on V1. Desmopressin works only on V2. So now since we saw this, terlipressin, this is the drug currently approved as the best medicine for esophageal varices. It is the drug of choice. Since it is a newer drug that has been made as the drug of choice, let's understand one thing loud and clear. Still, the most common drug that is used for esophageal varices, it is octreotide. Imagine both are given in the option and they are asking you best medicine. I would go with terlipressin. Maybe my opinion is different from other faculties, but this is the answer according to me. That is the best medicine as of now. Okay. Next, desmopressin, if you check, this guy saves water. The name itself is saying, right, this guy saves water, desmopressin. Now, what are the diseases in which you want to save water? Diabetes insipidus and nocturnal enuresis. You know, nocturnal enuresis is called bedwetting. The person is urinating too much. In urination, do you want to add more water? Obviously no. I want to save water so that the urination will reduce. Although the best treatment for nocturnal enuresis is what we call as bed alarm. Okay, this becomes the best treatment. It is known as bed alarms. Cool. So this is the logic. Now that we have said this, we have something called congestive heart failure. Okay. So what is congestive heart failure? See, this is the topic in which the person's heart become very weak. Okay. So ejection fraction reduces in this people. In acute heart failure, ejection fraction is very less. Okay, ejection fraction is extremely less in this patients. So what do I want to do? See, what is ejection fraction? Think of it like that, the amount of blood ejecting out of the heart, to make it simple in the head. If you contract with more force, more blood will come out. Since the patient's heart has become extremely weak, I need to increase the force of contraction called inotropy. And this can be achieved by a medicine called dobutamine. So dobutamine will give you which effect? Inotropic effect. Inotropic effect. Done. Next, usually with heart failure, you all must know pulmonary edema will come, and that's where you give furosemide. Next, chronic CHF. What do you want to do in chronic CHF? The aim here should be to decrease the workload on the heart, which will reduce the mortality. Okay, long-term management, what do you want to do? Reduce the workload on the heart. There are certain loads called preload, afterload that can be reduced by the drugs given in front of you. So this will be the simple mnemonic that you're going to use to remember this. Super cool bhai sahab. Okay, super cool bhai sahab. Okay. Now, the new drug approved in this topic, which could be potentially asked in your exam again, gliflozin. This is actually a topic of diabetes, which is recently approved to be used in heart failure also. All right. So this is the logic right here, gliflozin. Next, when it comes to digoxin, I want you to keep a tab on the toxicity part, please. Digoxin toxicity. Please keep in mind, digoxin toxicity, it is treated by one drug that removes digoxin from the body by binding to it called digibind. Nice name. Digoxin binding drug is digibind. It binds to digoxin, removes it from the body. Okay. And if arrhythmia has happened due to digoxin, then you will give a drug called lidocaine. Okay, then you're going to give the drug called lidocaine. Clear? Next is the drugs called anti-arrhythmic drugs. Okay, anti-arrhythmic drugs, as you can see, 4 main classes here. Now, one idea we must keep in mind starting from now itself, if you block potassium, then you may get one arrhythmia, okay, as a side effect. The side effect of this is called torsades, and this torsades presents as QT prolongation on ECG. Torsades presents with QT prolongation on ECG. Is that understood? And how do you treat this torsades? The treatment of torsades is magnesium sulfate. That's how you're going to treat the torsades. That may happen by any medicine in pharma who can block potassium. Now, one most important drug from this that I'm covering is called amiodarone. Amiodarone is the longest acting antiarrhythmic, very long half-life. Plus, it has multiple mechanisms. It is actually a class 3 drug, meaning it primarily blocks potassium. Apart from blocking potassium, it can block sodium also, beta also, calcium also. It's blocking pretty much every ion. So if you block calcium, beta, sodium, potassium, since this drug works everywhere, it can be used in almost every arrhythmia. Please remember, it's a wide spectrum antiarrhythmic. It's a wide spectrum antiarrhythmic. So it can be used anywhere, but where is it best? Ventricular arrhythmia. Although it can be used everywhere, it is best in the treatment of ventricular arrhythmias. Okay. Now, since we have said this, some side effects are there. Okay. Mnemonic that you got to remember. Better check PFT, TFT. Next, coming to the drug called adenosine. Adenosine is a drug having very short half-life. Right? Very short half-life. It's quite contrary to amiodarone. Now, where is this drug adenosine used? Adenosine is the drug of choice for the treatment of acute, situation like PSVT. This drug adenosine, although it is the drug of choice in that situation, since it causes bronchoconstriction, avoid in asthma. So what in your exam, if tomorrow they will ask you a question, what is the treatment of acute PSVT in asthma patient? Since you cannot use adenosine, answer is verapamil. Verapamil becomes the drug of choice for the management of acute PSVT in which patients asthmatic. Now, how about the long-term management? Verapamil is the drug of choice for prevention of SVT, PSVT. That means if you want to use a long-term medicine, right, that is going to be verapamil. But in hospital management, we'll be giving adenosine. Okay. So these are the highest yield things. Make sure you know some side effects of antiarrhythmics like amiodarone 1, and you should know the drug of choice. Last topic of cardiovascular, we got anti-hyperlipidemics. Okay. Our aim is to reduce cholesterol, right? So what do anti-hyperlipidemics do? They do three things. They will increase the good cholesterol called HDL. They will reduce the bad guys called LDL and triglycerides. They will be reducing these guys. Now first, what is the best medicine to reduce LDL? See, the maximum effect to reduce LDL comes with statins. Okay. And statins, how do they work? They block that main enzyme of cholesterol production called HMG-CoA reductase. Okay. Now these drugs should be avoided in pregnancy and children. Next, what is the best medicine to reduce the triglycerides? The answer is, it's a wrong arrow. To reduce the triglycerides, the best drugs are fibrates. So fibrates, how do they work? Fibrates are those drugs that will increase one enzyme called lipase. Now think about it. To keep it simple in the brain, lipase will break fats like triglycerides. Let's remember it like that. Lipase means it breaks fats. Let's remember which fat? Triglycerides. Although the mechanism actually is little different. So how can fibrates increase this enzyme? They will call out the roll number to make this enzyme. The roll number is called PPAR alpha. So when you call this roll number, basically fibrates will call this roll number PPAR alpha. Lipoprotein lipase will increase, and when lipoprotein lipase increases, triglycerides will decrease. They are the best medicines for triglycerides. Next, niacin. Niacin is the best drug to increase the good cholesterol. Okay, this is the best drug to increase the good cholesterol. Sometimes some side effects may come by niacin. Okay, how can you reduce those side effects? By adding drugs like NSAID, example aspirin. And niacin is not so nice. Avoid in diabetic people. Okay, avoid in diabetes. Okay, now since this part is done, we can move to the next part. Main drugs, 3 drugs. Best drug for increasing HDL, niacin. Best drug for reducing LDL, statin. Best drug for reducing triglyceride, fibrates. And what is the medicine to be used in pregnancy and children? The answer is bile acid sequestrants, the drugs having chole in the name. Okay, chole word is related to bile or gallbladder, yes, so that's the word chole. So cholestyramine, cholestyramine, etc. These are the medications to be used in pregnancy and in children. Now, since we have said this idea, what we are going to do in this picture is all the important side effects that we get to see in these chapters of ANS, CNS, etc. That's something I'm going to put up here, right? So first thing, cheese reaction, severe hypertension, we already said it's seen by a drug called tyramine. Okay, Coombs test positivity, it is seen by somebody called alpha methyl dopa. Cyanide toxicity, cyanide, the ide in the name, nitroprusside. Nitroprusside, that's the drug that's going to do this. Gingival hyperplasia, ankle edema, this is seen by CCBs, especially the drugs like dipines. Dipines are going to do this. We already saw dry cough angioedema, this is by the drugs ACE inhibitors, known as pills. Xanthopsia means some vision problems. This is seen by a drug called digoxin. Okay. Next is synchronism, presenting with ringing sensation in the ear called tinnitus. This is seen by a medicine called quinidine. Any drug having quin in the name, they may cause synchronism because quin drugs are derived from a plant called cinchona plant. There are drugs called shipped drugs. They will be causing SLE. Let me just iterate them once here. Sulfonamides, hydralazine, isoniazid, procainamide, and dapsone. These are the 5 drugs who can do this. Corneal deposits, pulmonary fibrosis. This is done by the drug called amiodarone. Amiodarone. See, one thing should be clear in your head. Now is not the time where you can understand too much about pharma. What you had to do is up till now. Now is the time we want to score. तो कौन सी चीजें, the things that are asked more frequently, that's what highest of the highest yield stuff I'm covering here. They may look like factual points I'm writing, but unfortunately that's what you got to do if you want to score. Okay, myopathy or myalgia, this is seen by statins. We just now said flushing or pruritus, it is by niacin. Okay. There was a powder called Nycil for itching. You may remember niacin, itching word. Okay. Purple toe syndrome, this is by a drug called warfarin. And coronary steel, dipyridamole. So this is the whole list. Okay, don't you guys worry. This is the file that I'm going to share with you guys. So coronary steel phenomena, this is dipyridamole. Done. Next topic that we get into, it is known as diabetes mellitus, anti-diabetic agents. Now, what do you need to understand is majority of the insulins are given by subcutaneous route, except one guy given IV. IV has a more predictable response, etc. So because of this reason, IV insulin called regular is used in the treatment of emergency called DKA. The insulin to be used here is regular insulin. And now we have a new insulin called Afrezza. Okay. Afrezza is inhalational. Afrezza is inhalational insulin. All right. Now, insulin will cause hypoglycemia, no doubt about it. And it will cause something called lipodystrophy at the site of injection. Dystrophy means something wrong. Okay. Dystrophy simply means something wrong. It could be atrophy. It could be hypertrophy. Okay. Now, when it comes to rapid insulin, what do you think rapid means? Rapid means they are absorbed rapidly and they last for a lesser time only. Okay. They last for around 4 to 5 hours. That's why they are called mealtime insulins. You got to take them before meals. They are rapidly absorbed, so they will get a curve like this. That means you give the insulin, quickly it will be absorbed like this. Quickly comes, quickly goes also. Then you have long-acting insulins looking like this. Okay, so what is the difference in this? Check this out. Mealtime insulin. Mealtime means they're coming quickly into the bloodstream. Because they come quickly, they will have highest risk of hypoglycemia. Okay, now simply remember this. These are the insulins. You may remember as the word GAL or lag, whatever it is, GAL or LAG. Okay, and these are the long insulins. See, rapid insulin has a peak. Because of the peak, you're getting hypoglycemia. But if you check this guy, long-acting insulins, they're called peakless because they don't show a peak. Because they're peakless, they have less risk of hypoglycemia. Okay, they have less risk of hypoglycemia. Now that this part is done, let us move on. Sulfonylurea. Okay, sulfonylurea. Now we are talking medicines used in diabetes. Sir, when you talk about sulfonylureas, they are the drugs that increase insulin release by working on pancreas. There are some channels called potassium channels. Okay. Now that we have said that, let's check this out. They are the drugs, almost diabetes drugs will have what in the name? GL in the name. Glyburide, glipizide, etc. They all have what? GL in the name. Now that we have said that, the side effect of sulfonylurea, because they increase insulin, they can also cause hypoglycemia. Finished? Next are these drugs called GLP-1 agonist. These are the drugs like, dulaglutide, semaglutide, etc. Semaglutide, the most famous drugs these days for the weight loss now, for the weight loss. Okay. So I told you SEMA is targeting weight loss. You got to remember semaglutide, famous drug for the weight loss. So these are called GLP-1 agonists. They basically suppress your hunger. They give you satiety. They suppress your hunger. All right. Next is GLP-2. It's a different thing. GLP-2 is going to be used in the disease apart from diabetes. GLP-1 is useful for diabetes, not the 2. GLP-2 is used for another issue called small bowel syndrome. Okay. Next we got this drugs called gliptins. Now, so far what they have asked a question in gliptins is, which gliptin is safe in renal failure? Okay. So basically that gliptin which is safe, it is known as linagliptin. We may remember linagliptin is excreted via liver. That's why it is safe in RF. All the other drugs are excreted by kidney primarily, except which one? Linagliptin. So linagliptin is the only one that is excreted by liver, hence it is safe in the renal failure. Okay. Next comes this part. Metformin. If you talk about metformin, friends, metformin comes in a class called biguanide. As you can see, what does it do? It blocks gluconeogenesis. That's how it reduces the sugar levels. Okay. Now let's remember, these are the two drugs that will actually reduce resistance that you learn in type 2 diabetics. Right? It reduces resistance. We must keep in mind that this guy, metformin, is the drug of choice for type 2 DM, and it's also used in PCOS if you want to reduce the resistance part. Very important point, metformin should be avoided in renal failure patient. Okay. Next is glitazones type of drugs. These are called glitazones. They work on a role number called PPAR gamma. Okay, PPAR gamma. G for gamma. See, why am I saying this word G for gamma? Some time back we learnt a drug called PPAR alpha. Right? We had a drug called PPAR alpha. So what I am trying to tell you here is PPAR alpha was useful somewhere. Where was PPAR alpha helpful, sir? PPAR alpha was useful in lipid topic. Okay. Now let me tell you something. There is a drug who works on both PPAR gamma and PPAR alpha. Okay. PPAR gamma plus PPAR alpha. It's called saroglitazar. So obviously it's working on gamma, so it's useful in DM. Okay, it's working on DM. And second thing, it is working on alpha, so it's useful for dyslipidemia. Okay, it is also useful for dyslipidemia. So this is the logic here. New drug expected in the exam because it's diabetes we are talking. Diabetes ke drugs are always high yield even though they might be new, my friends. Okay, so this is what I wanted you to know for sure in this topic. Okay, cool. Now next part, this is again becoming very hot topic. I'm expecting this to come in your exam. Okay, what is this? The drugs like semaglutide, etc. Okay, so what is the story of semaglutide? I told you just a mnemonic, सीमा को weight loss करना है. Remember, the drug is called semaglutide. Now there is one more drug that has been approved, like quite famous these days. That also I'll include in this. Okay, so there is a medicine called by the name of tirzepatide. Okay, this medicine goes by the name of tirzepatide. Now, what exactly is tirzepatide? This is also a drug that is a GLP-1 agonist. Additionally, it has one more mechanism. There is a thing called GIP, gastric inhibitory polypeptide. So it is a drug that will be working on both. So simply put, GLP-1 agonist plus GIP analog. This is a drug called tirzepatide. Again, this is a drug used for weight loss these days. This is a very expected type of a question that you can expect. New drugs are there, yes, in diabetes, but they love to ask diabetes wale drugs. So whatever potential was there, I have already told you. Next is this, my friends, alpha glucosidase inhibitors. Now, what is the story of alpha glucosidase is? You guys must know simply this. If you take this drug's alpha glucosidase, you cannot absorb the carbohydrates. So nice name, acarbose, absence of carbs. You are eating something, not getting them into blood. That's why the sugar will not increase. You are eating something, not absorbing. So they must be in the GIT, causing GIT side effects. Flatulence, diarrhea, etc. These are the GIT side effects. Okay. Now, this is one drug you must remember for diarrhea. Another important drug that you may remember for diarrhea is metformin. Okay. Another drug that can cause diarrhea in certain people, it is metformin. Cool. Now, since this part is over, gliflozin, your favorite drugs, This is how I used to teach you. If you remember, Gli flows in, GL for glucose, FLOZ means flows, IN urine. When you take these drugs, glucose flows in urine. That is how you're going to remember. Glucose flows in urine. So these drugs cause glucoseuria, because of which they can cause UTI. Now, what is the full form of SGLT2? They don't just make you lose glucose, but they also make you lose sodium. Since you're losing sodium plus glucose, loss of sodium can help you in heart failure. So now the use of these drugs, new use is heart failure, CHF. If you all remember the mnemonic, super cool bhai saab, super cool bhai saab. So that is all about the topic, diabetes. Next, I'm just going to take a few minutes breather, and soon after that we'll be continuing with this section, that is the thyroid topic, etc. Okay, so 5 minutes break will take. All right, everyone. So welcome back again. As I told you, the diabetes drugs, they're over now. So next thing that we'll be talking here, it is the drugs that we use in the thyroid topic. Now check this out. When we talk about thyroid, anti-thyroid drugs, it simply means these are the drugs treating hyperthyroidism. Okay, they treat hyperthyroidism. How can you treat hyperthyroid, meaning too much thyroid hormones? By reducing the production of thyroid hormones. This can be achieved by the drugs called methimazole, carbimazole. Please remember, they are overall the drug of choice when it comes to hyperthyroidism. Even in pregnancy, the last 2 trimesters, meaning second and third, we will be using these drugs. If you make a mistake of using them in first trimester, the baby will suffer this teratogenic effect. Okay, esophageal atresia, etc. So what do you use in the first trimester of pregnancy? Propylthiouracil. So propylthiouracil, called PTU, this happens to be the drug of choice in the first trimester of pregnancy, and it is also the drug of choice in the thyroid storm. Although the first medicine to be taken to control arrhythmia aspect, it will be beta blockers. All right. So quick reminder, first trimester PTU, second and third trimester methimazole or carbimazole. Next are the drugs that we use in the reproductive system. Now we got drugs like letrozole, very important. This drug is called aromatase inhibitor. What does aromatase do? Aromatase enzyme, it converts something called androgen to estrogen. So logically, the aromatase inhibitors, they will be blocking this. If you block, logically the estrogen will reduce. And this is the reason these drugs are useful in breast cancer, because in breast cancer, we want to reduce the estrogen. If the question asks you, premenopausal breast cancer, what do you give? Premenopausal breast cancer, you're going to treat by a drug called tamoxifen. Tamoxifen is given for premenopausal and the other one is postmenopausal. That's it. Okay. Now, since we said this, mifepristone. Now, what is the story of mifepristone? Mifepristone is a medication that we use in abortion. Many of you are already well aware of this. So, how do you give mifepristone? For example, the first day when you want to do abortion, you're going to take mifepristone 200 mg. Right? Single tablet would be there. Next is misoprostol. Misoprostol also comes in 200, but this time the dose is smaller, that is micrograms. So both are 200 only. This is 200 mg, this is 200 mcg. But this 200 mcg tablets are how many? 4. There will be total 4 tablets. 200 into 4 let's write it like this, no confusion. 200 mcg into 4 tablets. So total it will become how much? 800 microgram. This is how we should take it. Day 1 you take this, then give a gap. Day 3 you're going to go for misoprostol. Okay, so day 1, day 3. So now, since we have said that, this is the thing that is preferred up till certain age. You can check in your gynecology, up till 7 to 9 weeks, that is the range where we prefer drugs to do abortion. After that duration, whatever they tell you in gynae, please follow that duration only. I'm giving you a rough idea. After that duration, we'll be doing surgical intervention called suction evacuation. Okay, so you got to read, like, are they giving in this weeks or that weeks, which is the better management for abortion. Okay. Next is 5-alpha reductase inhibitors. Now, what is 5-alpha reductase inhibitors going to do? See, what does this enzyme 5-alpha reductase do? It converts testosterone to dihydrotestosterone. Dihydrotestosterone increases the size of prostate and it causes hair loss. Okay, that's what is the story of DHT. And this is all happening by an enzyme 5-alpha reductase. So logically, if I block 5-alpha reductase, DHT will also reduce, reduction in the size of prostate and reduction in the hair loss. So that's all these drugs are, 5-alpha reductase inhibitors. They're examples like finasteride, etc. So they will be reducing DHT. Reducing the DHT will reduce the BPH as well as hair loss. Okay. So that is the simple logic till here. Next is this chapter. What are the important side effects that we must keep in mind? Let's go further. First thing is hypoglycemia. If you talk about hypoglycemia, friends, what do we need to remember is this. Hypoglycemia. Guys, let me know, like, are we doing okay now? Are we back? All right. Okay. We will see, like, in case it get stuck again, we will lower the video settings or something. Some technical glitches happening, maybe it's due to internet or something. All right. Now let's move, as long as this guy is working okay, so we can continue, I believe. All right. So as you see, we have talked about these medications right here. So lactic acidosis, the next side effect that we are talking is lactic acidosis. This is seen by the medicine called metformin, what we said. So this type of tables are just a quick recap of the whole chapter's important side effect, etc. Okay. Flatulence and diarrhea. Make sure you by heart all this file that I'm going to share with you. Okay. Definitely important questions are going to come up from here. Okay. Next is flatulence and diarrhea. I told you acarbose type of drugs called alpha-1 glucosidase or alpha glucosidase inhibitors. Example, acarbose. Remember the mnemonic, absence of carbs. When you take these drugs, absence of carbs. Next is UTI, genital infection, etc. That is SGLT2 inhibitors like gliflozins. Again, the mnemonics I'm reminding you as a recap. Glucose flows in urine. UTI will happen due to this. Okay. Next is rash and agranulocytosis. This rashes, etc. are seen with methimazole or carbimazole. Okay, methimazole or carbimazole. The drugs we use in thyroid, they can cause rash most commonly. PTU is the hepatotoxic drug. For this reason, we avoid it in the second and the third trimesters because the baby's liver has already formed. Okay, that's the reason we kind of discontinue this medication. Esophagitis, osteonecrosis of jaw, it is by the drugs called bisphosphonates. Bisphosphonates are the medications what we call by the name of dronate. And bullseye maculopathy, famously it is caused by the drug called hydroxychloroquine. Hydroxychloroquine, important side effects. Okay, so that is it about endocrinology. Next is autocoids chapter. Histamine is the first topic. The basic idea that you got to remember is with the topic histamine, there are drugs called antihistaminics used in allergy. Now there are two types of antihistaminic. First generation antihistaminics, what you are looking at right now, these medications, they cause sedation and they block muscarinic receptor, which gives them extra property, example antiemetic effect also. So long story cut short, first generation drugs have sedative property as well as antiemetic. Hence some of them are used for some vomitings like morning sickness, motion sickness. Second generation drugs, they cause less to no sedation. Less to no sedation. Example of least sedative drug is fexofenadine. Okay, fexofenadine is the least sedative drug from the list. Now since we all got this much idea, we can move further in this serotonin topic. So in the serotonin, we got this very high yield drugs like triptans, which are used in migraine. Now as of now, you can look at 5-HT3 blockers. They're called cetrons. Cetrons are the drug of choice for chemo or radiation induced or post-operative vomiting. Okay, so cetrons are 5-HT3 blockers. Next, we talk about migraine as a topic. Migraine, if you want to prevent, the best drug for the long-term maintenance is propranolol. Propranolol. Propranolol is the best medicine. If contraindicated or something, you can go for other medications, use others. Example, topiramate. Okay, so simply I'm saying that use topiramate. So propranolol is over. Next, let's talk about the treatment. Treatment of migraine, if it is mild to moderate, we must go for simple drugs to reduce the headache called NSAIDs. And if it is severe, then we should go for the drugs called triptans. Now, triptans needs to be avoided, contraindicated in ischemic heart disease, IHD. IHD means ischemic heart disease. They are contraindicated. Example, MI. In MI, we cannot use triptans. So that's where we got a drug, okay, called lasmiditan. Full name is like that. I mean, I have just broken it down into pieces to help you remind this. This is the drug that gives you less MI. Okay, this is all we are going to remember. This is the drug that is giving you what? Less MI. That's it. This is the drug simply known as lasmiditan. Okay. Now, since we all got this, end of this topic, so whatever I discussed just now. And one last mnemonic that you should also remember here, it is this, ergots. You must remember this mnemonic, ergots, rots, fingers. That means they tend to cause gangrene. Okay, they tend to cause gangrene. Ergots, rots, fingers. The names like ergotamine, dihydroergotamine, they have ergot in the names. And how do you treat this gangrene if they ask you? The answer is nitroprusside. Okay, you're going to see this known as nitroprusside. Okay, So above I wrote already, you can use other drugs, example topiramate. Now I've already given the list of the other drugs that you can use in the prevention. Okay, next is some prostaglandin drugs. PGE1, PGE1 analog. You must remember in this topic called PGE1, you got a drug called misoprostol. So misoprostol is a drug that looks structurally like who? PGE1. Analog means a drug that looks like the original one. Okay. Now since we said this, let's keep an idea. Where is misoprostol used? We already talked about abortion. It's also used in peptic ulcer disease. It's also used in peptic ulcer. Remember just one rule what I'm teaching you now. Prostaglandins, they are pro-stomach. That means they are the friends of your stomach, pro-stomach. That's why they're useful in peptic ulcer. So if you increase prostaglandin, you can treat peptic ulcer. And if you decrease prostaglandin, it will produce ulcer. And who decreases this? NSAID. That's why you get NSAID-induced ulcer. Are you understanding the logic? Reduction in the prostaglandin will cause this. It is called NSAID-induced ulcer. All right. Now, since we have gotten that, next part is PGF2 alpha. PGF2 alpha. These are the drugs called Prost. They are the drug of choice in open angle glaucoma. Okay, they are the drug of choice in open angle glaucoma. I usually say remember the side effects by this word only. PGF2 alpha na? PGF2 alpha, that's how you should be remembering them. What is PGF2 alpha? Pigmentation of iris. They cause darkening of your eye color. Growth of eyelashes. Okay, growth of eyelashes. Another side effect. F for how do they work? They increase the flow called uveoscleral outflow. They are the guys that will be increasing uveoscleral outflow. Okay, so that is the simple logic. They increase the uveoscleral outflow. So that's how you can remember this. And last thing, their side effect, because they are prostaglandins, they can increase inflammation. And because they increase inflammation, we should avoid in any inflammatory situation like uveitis, macular edema, etc. Avoid them in these situations. Okay. So that's all about this. These are the drugs you can simply remember in this fashion. Next, if they ask you what is the drug of choice for open angle glaucoma, your answer should be PGF2 alpha agonist. I told you they cannot be used in inflammation like uveitis. Then what to use? Brimonidine. Next is, if you talk about closed angle glaucoma, we can use pilocarpine. Pilocarpine becomes the drug of choice in the maintenance. Treatment of choice in this situation is laser iridotomy. Closed angle is mainly treated by surgical intervention. Okay. Now there is an emergency situation called as acute congestive glaucoma or ACG. Please remember, although this is nothing but closed angle glaucoma only, but emergency, more serious. Don't say pilocarpine as the answer. Initially, you will start the treatment like mannitol or acetazolamide. First, diuretics are given in emergency. So if they ask you ACG, don't say, sir, you said pilocarpine. I am clearly telling you mannitol or acetazolamide. After the pressure comes down in the eye, now you can move to pilocarpine later. So pilocarpine is more like a maintenance drug, right? It's more like a maintenance drug. Next is glaucoma medications. How do they work? Two ways. This increase in intraocular pressure is due to the fluid called aqueous humor. So what do you want to do in glaucoma? Either you want to increase the drainage, you want to remove more from the eye, or you want to reduce the aqueous humor synthesis. You can reduce the production or you can increase the drainage. So what are the drugs working like this? First, the rule of thumb that I always teach is this. Majority drugs, simply you can say most drugs in this topic, how do they work is they reduce the production of aqueous humor. And here also there is a mnemonic that we can take called ABCD. Okay, so we got ABCD as the mnemonic. What is from the A? It is alpha 2 agonist like brimonidine, etc. B for beta blockers. C for carbonic anhydrase inhibitors like acetazolamide, carbonic anhydrase inhibitors, and D for epinephrine like drug called dipivefrin. Okay, so that's it. That's an easy mnemonic you can recall. Next, the drugs that increase the aqueous humor drainage. What are these drugs? Two ways. There are two drainage pathways in the eye. Number one, trabecular meshwork. Number two, uveoscleral. Uveoscleral, I already told you this is increased by the drugs called PGF2 alpha agonist. The drugs called Prost. Okay, Prost medications, they increase uveoscleral. We already learned this. Yes. Next is if you talk trabecular meshwork. Okay, trabecular meshwork, we all need to know something. Meiotic drugs can increase this drainage. Who are the meiotic drugs? Example like pilocarpine or physostigmine. Pilocarpine or physostigmine. Next is alpha 2 agonist. Example apraclonidine or brimonidine. Okay. Last is something called Rho kinase inhibitors. There is a drug called netarsudil. Okay. So three types of drugs, they increase trabecular meshwork. Glaucoma काफी important topic है. So we have pretty much everything covered so far in the glaucoma. How do they work? Either they reduce production or they increase drainage. What are the two pathways in drainage? One is trabecular meshwork, another is uveoscleral. Where do the drugs like meiotics work? Trabecular meshwork. Pilocarpine, the main drug of closed angle, works here. Prost, the main drugs of open angle, they work on the uveoscleral. That's about the mechanism aspect. Okay. Next is this part, that is about the drugs that are in the glaucoma, what are their side effects, etc. I will send you a filled part of this anyway. Okay, right now in the session, me writing this will consume some time. Okay, so don't worry, this drugs, which one is answered in this section, I'll share that with you. Just now a side effect which we discussed, remember, pigmentation of iris. This is happening by the drugs called as Prost, PGF2 alpha drugs, PGF2 alpha. I told you P for pigmentation of iris, darkening of the iris. Okay. Now, since we have talked about this, next is the drug called netarsudil. Netarsudil, this is the drug that will cause this side effect called cornea verticillata. So they are called whorl deposits. I don't know if you're able to see this in the image. Are you seeing this kind of lines that are appearing? This is called cornea verticillata. This is primarily by netarsudil, or there are some other drugs also like amiodarone, etc. that can do that. Okay, so even the drugs like amiodarone, which are not from this chapter, they can also cause this cornea verticillata. Okay. Now, since this is over, just a while ago, I mentioned to you that NSAIDs are the drugs that will reduce prostaglandins by blocking an enzyme called as COX. And when you reduce prostaglandins, they may cause peptic ulcer disease as a side effect. Now, here's where you need to understand something loud and clear. There are two types of COX. Actually, there are three. So, as of now, discussion mein COX1 and COX2. If you block COX1, Okay, if you block COX-1, the side effect will be you will get peptic ulcer disease. If you block COX-2, you will not get peptic ulcer. Only if you block COX-1, you will get peptic ulcer. That means only the drugs called non-selective, because they block COX-1, they will cause peptic ulcer disease. And who's not going to cause this? The answer is COX-2 inhibitors. Selective COX-2 inhibitors, they are not going to cause peptic ulcer disease. So you can remember no peptic ulcer disease by these drugs, and they are called as COX-SIPs. Okay, they are simply known as COX-SIPs. Now this is the simple idea. Right here you should get no peptic ulcer by this. Clear? Next, as you saw this COX-SIP words, easy peasy, no peptic ulcer by these drugs. Now when you talk about paracetamol, also known as acetaminophen, please remember it's a COX-3 inhibitor. Paracetamol, it's a COX-3 inhibitor. Always and always a favorite question of the board. Please remember that this is the drug that may cause hepatotoxicity. Okay. Maximum dose that we give with paracetamol in a day is 4 grams per day. 4 gram means 4000 mg. 500 mg tablets into 8. Total 8 tablets you can give in one single day. Toxic doses, roughly some books say 7.5 to 10 grams. So the dose above 7.5, 8, etc., that means that is considered to be toxic. Most textbooks have 10 gram as the toxic dose. Okay, let's remember maximum is 4 gram and 10 gram above is dangerous. What does it do? Hepatotoxicity. Next, you must remember, like imagine somebody took such a high dose. Usually first day your liver is trying to remove this drug from the body. Hepatotoxic now, liver is the one who is metabolizing, it is now overloaded. So first day in the toxicity you can expect the increase in the liver enzymes. Liver enzymes will increase in the first day. Second day onwards you can expect some symptoms. After first day only we can expect some symptoms. Okay. Now what is the antidote? What does it do, etc.? First, who causes the hepatotoxicity? The answer to this is one villain called NAPQI. This NAPQI reduces one good guy called as glutathione, which is an antioxidant. Okay. Now that we said this thing, we all know there's an antidote called NAC, N-acetylcysteine. You will memorize like this: NAC opposes NAP. NAC opposes NAP. So when the NAP is blocked, you must remember what will happen. Glutathione will come back. That's it. That's how your PCM toxicity happens. Okay. Now since we saw this much, next disease is called gout. When you have acute gout, meaning patient comes with swelling in their big toe, the aim is to reduce inflammation. And what do you do to reduce inflammation? You will give anti-inflammatory drugs like NSAIDs, especially indomethacin. There is one more drug called colchicine. Colchicine will stop the inflammation by stopping neutrophils from going to the site of inflammation. You all must be knowing neutrophils, if they go to the site of inflammation, they will cause pain. So colchicine stops all that. Cool. Next is chronic gout. So if you and I are talking about the chronic gout, what we must know is simply this, my friends. The aim here is to decrease the uric acid. Long-term management means I want to reduce uric acid. How can I do that? Reduce the production of uric acid. Okay, reduce the production of uric acid by blocking one enzyme, xanthine oxidase. Now you may remember this. See, xanthine oxidase comes from purine. This uric acid comes from purine. So you got purine in the name here, allopurinol. So if you have low purines, you will have less uric acid. Simple logic. Febuxostat, xanthine oxidase inhibitor. All right. Febuxostat is used if there is allopurinol allergy. Okay. So if there is allo allergy, then I'm going to go for febuxostat. Next, uricosuric means they increase the excretion of uric acid. Example, a drug called probenecid. Probenecid is not reducing the production. What do you want to do? It is going to increase excretion. All right. Last is uricase analogs. Uricase, as the name says, it breaks down uric acid. Uricase breaks down uric acid. All right. So now, since we said this, uricase breaks down uric acid, what is the idea? This is the uric acid. So what do these drugs, uricase analogs, do? They break down the uric acid into a substance known as allantoin. Okay, they break it down into allantoin. They do this by oxidation reaction. And this drug, as the name has uricase in its name, this will break down uric acid, as I've explained. It's used in one situation called tumor lysis syndrome. Tumor lysis syndrome. So when tumor cells break, uric acid increases. So when sudden increase in uric acid happens, you need to take care by rasburicase. Okay, by this simple medicine known as rasburicase. All right. So we got this. This was the topic, autocoids, etc. Now the next part is your CNS. First, start memorizing like in which seizure, which drugs are used, because seizure is an important topic. So if the patient is having status epilepticus, we can go for the drug called lorazepam. Okay, lorazepam. What is status epilepticus? When somebody has seizure for greater than 5 minutes, we use a drug called lorazepam. Done. Next is febrile seizure. What is febrile seizure? Febrile seizure means a child having high fever will get seizure now. So any of the two drugs are considered drug of choice. Both can be used, rectal diazepam or intranasal midazolam. Next, in pregnancy, for the seizures, the drug of choice is levetiracetam, or we can use lamotrigine. We can remember L for L as they are less teratogenic drugs. And the most teratogenic is valproate. V for valproate, V for very teratogenic drug. That's why we don't use it in pregnancy. Very teratogenic drug. All right. Eclampsia is a different situation. When you have uncontrolled blood pressure, you will get seizure. Okay, this is due to hypertension. Hypertension in pregnancy. This is where you're going to go for a drug called magnesium sulfate. This drug is very teratogenic and this drug is very wide spectrum. V for valproate, V for very teratogenic, very wide spectrum. So it's almost drug of choice for almost seizures. Although newer drugs today can be used, they are now called as first line drugs. So for GTCS, etc., now we can use some other drugs also. I'm not denying that. But generally for exam answering the drug of choice, we can go for valproate. Okay. Other drugs, what can I use? I can use lamotrigine also if I want to. They are actually more better. They are having lesser side effects. Okay. Next is focal seizure or partial seizure. Again, we can go for these drugs, but preferably carbamazepine. Although the lesser side effect drugs are lamotrigine, oxcarbamazepine, but better for exam, we can go for carbamazepine. Done. Next is infantile spasm. The drug of choice is ACTH. Salam seizure, that's the name we call it by. And imagine there is infantile spasm with something called tuberous sclerosis. Tuberous sclerosis. Then we go for a drug called vigabatrin. Okay, this is the drug called vigabatrin. That is the simple logic right here. Vigabatrin will be that medicine. Done. Next is there are certain medicines called barbiturates or benzodiazepines. They are the drugs usually working on the GABA topic. As the name says, GABA, they work on certain receptors called GABA A receptor. Okay. Barbiturates, they have one side effect. They increase enzymes. They are called enzyme inducers. Whereas benzodiazepine, they don't have any such side effect. Antidote, if you talk about, please remember benzodiazepine has an antidote called flumazenil. So this is the mnemonic I teach you guys. Again, reminding you, Benz mein full maze. Benz mein full maze. Mercedes Benz, you're enjoying Benz mein full maze. Okay. Next is barbiturates, which are actually more serious drugs. They don't have an antidote. But if you see the name 8, these are drugs derived from acids. 8 generally means acidic drugs, not always. So what do you need to know is acids can be removed from the body by making them uncomfortable. And how can these drugs become uncomfortable? The answer is by putting them in the opposite environment. There is a thing called forced alkaline diuresis. Okay, so what is this thing known as? Forced alkaline diuresis. Because the drugs are derived from acid, we are doing alkaline environment. That's how you can remove this medicines. Okay. Now, since this part is done, please remember some points, at least in the common drugs. Diazepam and lorazepam are the famous drugs. The one which is safe in the liver failure patient is lorazepam. The one which is dangerous, D for dangerous in liver failure, is diazepam. And the same rule applies for elderly also. Elder people don't have a good liver. So which drug should you avoid in elderly? Diazepam. And which drug is safe in the elderly or in the liver failure? Lorazepam. Okay. So that's all I am saying this. Finished. Next comes the drugs we use in depression topic. Antidepressants. Okay, so if you look at antidepressants, my friends, the simple logic is here. There are one type of drugs called TCA. What do? TCAs increase serotonin and noradrenaline. Important drugs to be remembered are nortriptyline, amitriptyline, imipramine. What are their side effects? They additionally block some things. Histamine alpha muscarinic. Histamine alpha muscarinic, these are the things that they are blocking. Okay, now that we saw that, let us move further. One class of drugs in this topic were TCA. Second class of drugs in this are called SNRI. Third class of drugs are called SSRI. SNRIs also increase serotonin and noradrenaline. So, sir, mechanism if you check, TCAs also do this, SNRI also do this, but what is the only difference between the two? It is the side effect. TCAs are going to cause the side effect, that is they block HAM, which will cause respective side effects. Example, alpha block reduces BP. Histamine block causes sedation. Muscarinic block, opposite of dumbbells. All these things are going to happen. Next is SSRIs. SSRIs are considered the drug of choice for majority of the situations called neurosis. They are used in depression and they are also used for neurosis. Okay, please remember they have some sexual side effects. They cause this thing called anorgasmia. Anorgasmia simply means they delay ejaculation. Okay, they delay ejaculation. Cool. Next, some other antidepressants are there. Please remember the drug with least sexual side effects in depression topic is called mirtazapine. Okay, mirtazapine, this is the drug causing less side effects. Okay, now that we have said this, next is a medicine that we tend to call by the name of lithium. So lithium is used in this situation called as bipolar disorder. Okay, lithium is used in bipolar disorder. Sir, lithium drug ko na simply remember like lithium batteries. Lithium should remind you of batteries that we have. And lithium battery mein what is present, if you notice, plus and minus symbol. So it controls you when you have excess activity called mania. It controls you when you have less activity called depression. Okay, there is something called BDNF. So this is the drug that stabilizes the levels of BDNF as required. That's why it is called as what? Mood stabilizer. Lithium ke side effects you must know, sir, and this comes by the word lithium itself. Okay, lithium word should remind you of this, lithium. Okay. Now, as you see here, we have already said this. One more side effect I'm adding. Mouth mein they cause burning. So basically this is your lithium side effects. All of you must be knowing very basic thing that there is a concept called low therapeutic index, meaning these are the drugs having very dangerous effects. See, for example, for the treatment, you might have to use a level or maintain a level of 1.2 milliequivalents per liter. Same drug, if it becomes little higher, that is 1.5, it becomes dangerous. This kind of drugs are called narrow spectrum, all right, or narrow therapeutic index. My bad, not narrow spectrum, they're called narrow therapeutic index, all right. So that's about bipolar disorder. Okay, now next that we have in the list is antipsychotic medications. So when you look at the antipsychotics, my friends, we must remember what do these drugs do? They block dopamine. And if you block dopamine, you can expect some side effects called EPS. EPS means extrapyramidal side effects. So there is this whole table here, as you can see, this is called as what? EPS, extrapyramidal side effects. Now that you have seen this, examples of the drugs that you must remember, as I am telling you, some drugs in this have less risk of EPS because they are low potency. But what do? They block some other receptors. Okay, they block 3 receptors called HAM, histamine alpha muscarinic. So they are HAM blockers. Are you understanding this? They block other receptor. They are not causing EPS, but they will cause some other side effects. If you see haloperidol like drugs, they have higher risk of EPS. Okay. In this list, if you see risperidone, clozapine, aripiprazole, these are the drugs. One of the drugs with very less EPS in this list, less EPS is clozapine. Clozapine doesn't cause as much EPS. Risperidone. What if tomorrow, imagine you get one question, which drug has zero risk of EPS? Zero risk. I'm not saying less, I'm saying zero risk of EPS. Now, if they ask you that question, then your answer will be here. There is a drug called pimavanserin. The name says it's a serotonin inhibitor. Because it doesn't block dopamine, it doesn't block dopamine at all. No EPS and no hyperprolactinemia. Now, if you're wondering what is this hyperprolactinemia sir is saying, now try to understand this. The logic is pretty loud and clear. When you block dopamine, what will happen side effects? One is EPS, second is increase in prolactin. These are the side effects. Okay, dopamine block karne se this will happen. In fact, you must be knowing dopamine is called prolactin inhibitory factor. Prolactin inhibitory factor. Okay. Clozapine, as you are seeing, this is the drug for resistant schizophrenia. Please remember this and read the remaining side effects of this drug. Coming to the question, 99% in the exam, this is the thing that they love to ask. It is what we call as EPS, extrapyramidal side effects. Maximum risk with drugs like risperidone or haloperidol. Okay. The mnemonic is adapt now. Okay, adapt now. You must remember how these things present and how to treat them. Okay, you will see this in your psychiatry subject also. Acute dystonia presents with muscle contractions like torticollis, etc. Torticollis or oculogyric crisis. Eyeballs roll up, oculogyric crisis. This is treated by a drug called benzhexol-benztropine. Okay. Same way, Parkinson is also treated by the same drug called benzhexol. At least people who have attended my class know the mnemonic Parcure-Benz. Parcure-Benz. Akathisia is motor restlessness. This is treated by beta blockers. Tardive dyskinesia is certain rabbit-like movements described like rabbit-like movements in the mouth, etc. Perioral movements, they're called tardive dyskinesia. They're treated by a drug called valbenazine. Valbenazine, this is the medication. Next is neuroleptic malignant syndrome. This is an hypothermia that can kill you. The treatment of this is a drug called dantrolene. Ryanodine receptor blocker that is used here called as dantrolene. Last, some miscellaneous side effect. Weight gain is maximum seen with drugs like olanzapine and clozapine. Okay, weight gain is seen with these drugs. Weight neutral drugs, that means they don't cause weight gain. They're drugs like aripiprazole or ziprasidone. Aripiprazole or ziprasidone. Now, the mnemonic that I usually teach you for this, hopefully you remember. If you take Ola cabs for very close distances, you gain weight. Remember this? If you go in Ola only for small distances, you're not walking and you will gain weight. So these are the two drugs, olanzapine, clozapine. The drugs that don't cause weight gain are aripiprazole and ziprasidone. If you walk from A to Z, long distance, you're not going to gain weight. Is that clear? Aripiprazole, ziprasidone. If you walk from A to Z, you will not gain weight. Next is hyperprolactinemia. This is very common with a drug called risperidone. What is the logic? If you block dopamine, you will get EPS, you will get more prolactin. Okay. So this is the list. Pakka is a question, 90% chance hai it will come in your exam. Don't miss it out, please. All right. So now that we have said this, we can move further. Anti-Parkinson drugs. Parkinson is a topic exactly opposite to psychosis. Here the aim is to increase dopamine or stimulate dopamine receptor. So that's why we have D2 agonist. We got some drugs called cabergoline bromocriptine. These drugs are actually used in the treatment of hyperprolactinemia. Ab you only think, sir, what did I explain to you? If you reduce dopamine, prolactin increases. Yes or no? What are Parkinson drugs doing? They are increasing dopamine. If you increase dopamine by Parkinson drugs, now the dopamine will reduce. So in which situation you want to reduce prolactin? In the treatment of hyperprolactinemia. So you must keep in mind what I'm saying next. Drug of choice is cabergoline. Pregnancy में drug of choice is bromocriptine. And these are ergot, same mnemonic, ergots, rots, fingers. All right. Next is, if you talk non-ergot derivatives, we got these drugs like pramipexole, ropinirole, rotigotine. Rotigotine is available in the form of a patch. This is the drug of choice for Parkinson, also used in situations known as restless leg syndrome, etc. Okay. Now the new drugs, the drugs that are preferred in restless leg syndrome are drugs like gabapentin, pregabalin, etc. Okay, they are the more preferred drugs for restless leg. We can use these drugs of Parkinson. Again reminding, the better drugs are gabapentin, pregabalin. Okay. Now, next thing, these are considered to be the best, drug of choice in Parkinson's. But if they ask you, let's say, most effective drug in Parkinson, then you should say levodopa plus carbidopa. You will get a doubt, if this is more effective, then why is it not drug of choice? Sir, you know that to save levodopa, you have to give many more drugs. This is a very old patient. I don't want to give so many drugs. This is single drug, either this or this, like that. One drug is enough. Here, multiple drugs are given. Since it's an old patient, I don't want to do that. I hope everybody got this. Since this is done, next, Parcure Benz, तो mnemonic याद है आपको? For drug-induced Parkinson, we use the Benz drugs, Parcure Benz. And you should know that benzhexol can also be sometimes given in exam as trihexyphenidyl. Trihexyphenidyl. That's just another name of this medicine. All right. Next, Alzheimer I've already finished. Okay. Now just one more drug I'll tell you here. Beta amyloid deposition on the brain causes Alzheimer. So if you want to reduce Alzheimer, you need to block beta amyloid. This can be done by these drugs, aducanumab and lecanemab. So you will remember for Alzheimer disease, aducanumab and lecanemab. Okay, so these are the monoclonal antibodies that are approved in Alzheimer's. Next is opioid topic. I think I told you opioid are those medicines. What do they do? Mechanism of action is they stimulate mu receptor. So they have clinical uses also, and they are abused also. That means stimulation of mu gives you some addiction, good feelings. That's why people abuse these drugs. Morphine, okay. You have some drugs like fentanyl used as anesthetics. People abuse that. Okay. So I am saying medically used also, abused also. So sir, if somebody has abused this drug and they come to us, how do you treat them? We give them antagonist, meaning I'll give them mu receptor blocker. Again, a quick reminder, how will a opioid patient come? OP poisoning or opioid, they both come with meiosis called pinpoint pupil. But how will you differentiate whether it is opioid or OP poisoning of farmer? OP poisoning of farmer will have some other features from dumbbells. Apart from meiosis, they will also have other features of dumbbells. Diarrhea, urinary incontinence, something like that. Here, instead of that, you will have respiratory depression and unconscious. Sir, if I am abusing a drug for enjoyment, it will give me some unconscious feeling, yes or no? Nashe ke liye karte hai na, we use these drugs for this. So, patient comes like this. What do? IV naloxone is the drug of choice as an antidote. Later on, long-acting drug, oral naltrexone can be given. Okay. Now, since this is done, All right, so I took a break for a minute. I just came back. It's lagging now? No, I don't think so. I just took a break. Now, check this thing out, sir. Last topic in this, that is your alcohol. Anyway, there will be some gap between what I am saying right now and by the time it is, coming live, there will be some lag in between. Okay. In case I take some break or something, you will get to know that little later. Okay. So, pharma boss, obviously, we need to spend some time. I'm trying my best that people who watch this session will get the maximum out of it. Yeah, all right, let's all pray. I hope that you will get good score from this session. Okay, that's what I want. So if I wanted, I could have finished it in 1 hour, 1.5 hours also. But this is a session that is helpful for most of you. That's my whole aim of this. Okay, it may be little longer. By 3 घंटे pharma को तो इतनी तो इज्जत से नवाजो. 3 hours you have to do at least, right? We started by 7. So you got to spend at least 3-4 hours on pharma. Around 20-25 question aa rahe hain, so 3 hours this subject deserves. Okay. So coming to alcohol as the last topic. If I have drank alcohol, there is alcohol toxicity. Please know the drug of choice for alcohol toxicity, it is called fomepizole. Fomepizole greater than ethanol. Even if ethanol is in the option, I'm still going to choose fomepizole as the answer. If there is withdrawal symptoms due to leaving alcohol, I'm going to go for chlordiazepoxide. Okay, chlordiazepoxide. Okay, so this is it. It's a long-acting benzodiazepine. Next is dependence. I'm a person who's addicted to alcohol. Now I want to quit alcohol. What is the drug you will give me? Disulfiram. Remember, I used to teach you, this drug has name of God. If you take the name of God, then you should not drink. Otherwise, you will get punishment. You're going to get some serious symptoms. If you take disulfiram and you drink alcohol, then you're going to get very bad symptoms. Okay. So this is the drug that is a punishment. God is giving you punishment in the name of disulfiram. Is that clear to all? Next, some drugs which were not intended to do this, but their side effect is just like disulfiram. 3 drugs, at least you must remember, most common cause of disulfiram reaction. Think of it like that, most common cause. 3 drugs they can copy. So what do you tell if you are taking these drugs? The simple logic is don't drink alcohol. Don't drink alcohol, otherwise you will be punished. Okay, so simply this is the logic right here. Okay, so let's take like a 10 minutes break or something, guys. 10-15 minutes break lenge, then we'll get started. And for the guys who are asking for the micro session, unfortunately, I won't be able to do a micro session. Earlier, I had a plan, but unfortunately, due to certain reasons, I will not be able to do it right now. So please watch the previous video itself. It contains a lot of important stuff. Don't you guys worry about this. Okay? So right now, let's focus on the pharmacology aspect. Don't be in that distraction asking about micro again. All right. So chalo abhi, let's take the break. Once we are back, we'll be finishing off with the revision aspect of pharma. Post this, we'll see the situation. I'll do the MCQs, after this or maybe tomorrow later on. Okay, one of the two things. As of now, 15 hours break, my friends. Okay. Hello. All right, everybody, welcome back again. So now we can get going again. See, I had told you that this kind of tables, which are just like a quick recap of the side effects of one system, this I'll fill it up and send you rather than just sitting and writing right now. Okay, so explanation part of things I'll be rather focusing on. Okay, so let's go. Next is hemat. If you talk about the hematology aspect, you must all know that first we have these drugs called blood forming drugs. And what exactly should you be learning in this is blood forming drugs. One of them is iron. Iron is usually absorbed in the ferrous form Fe2 from the duodenum. Okay, the things that increase iron absorption are usually those things that can increase acidity. Acid will increase the iron absorption. So this is the keyword that you all should know. Okay. Next, after this, the second thing is the things that will reduce iron absorption will be more alkaline, alkalis. Okay, the drugs like PPIs because they reduce acid. All right. Tea because tea contains some things called tannates, phytates, etc. Because of this, tea also can reduce the iron absorption. Next, we move further. If you are having too much iron in the body, we need to remove it by the drugs called chelating agents. Now, you must remember the chelating agent is here desferoxamine. We can pronounce it as deferoxamine. Defer means removal of iron. Okay. There are other antidotes also which are oral. The oral antidotes are deferriprone, again the same word defer, or deferrosirox, again the defer. Okay. Next is, you must keep in mind that bal is one antidote that can be used in the word bal itself, bismuth, arsenic and lead. Bal means hair also, right? In Hindi, bal means hair. We can remember bal, you don't want it in your cafe, in your coffee. Yes or no? So bal is not useful in cafe. What is cafe? Cafe is cadmium and iron. Cadmium and iron, we cannot use bal. So in iron, we use deferoxamine, etc. And for the remaining guys, bal, the word is bal. Okay. Next is the growth factors that we require for the blood formation. So first one is RBC. We must keep in mind erythropoietin, EPO. RBC के लिए we got erythropoietin, that is EPO. That's how the name has erythropoietin alpha beta. Okay. Now when you talk about platelets, the word is thrombopoietin. Thrombopoietin, if you see, the names of the drugs here are thrombopags, thrombocytes, agonist drugs. Okay, thrombocyte agonist. This interleukin 11 also increases platelets, and the drug that is interleukin 11 is called oprelvecin. We can remember it like this. Instead of this, we can add one N in between, and the number now becomes 11 kin. So you can kind of remember oprelvecin is interleukin 11, 11 kin, interleukin 11. That's how we can easily recall this. Last and the final, to increase the WBCs. So what are the WBCs? WBCs are increased by growth factors called granulocyte monocyte growth factors. So what are they? Let's check. You can see a word called GCSF. G stands for granulocyte colony stimulating factor. That's why the name is here. G stands for granulocyte. Stim means stimulation. Next is GMCSF, which means granulocyte monocyte colony stimulating factor. GRAMOSTIPs. That is granulocyte monocyte stimulating factors. Okay. Next, a very high yield topic for the exam that you should all know. It is known as anticoagulants. So if you talk about anticoagulants, first of all, you must all keep in mind, we got oral drugs, which are divided into direct and indirect drugs. Same way, injectable drugs, which are divided into direct and indirect drugs. Okay. So vitamin K inhibitors are called indirect drugs. Example, warfarin. Now you must remember, warfarin, the only place where I'm going to use this drug today is in the patients having mechanical valves. Okay, patients having mechanical valves. So in these patients, we give the drug called warfarin. Remaining other places, oral drugs are for maintenance now. So if you have an artificial valve, mechanical valve in the heart, I can give you warfarin as a medicine. Next, for other situations like venous thrombosis, example DVT, pulmonary embolism, whatever it is, if you want to do the maintenance, then the preferred drugs are DOACs. DOACs are generally the drugs used in prophylaxis of DVT, pulmonary embolism, etc., etc. They are the more preferred drugs. Okay. Now, since we have said this, what are the drugs in this? Factor 10A inhibitors called hexabans, antagonist of XA, and their antidote is called andexanet, antidote of dexa. Dexa means 10. Dexa means 10. Okay, next you have a drug called number 2 inhibitor, direct thrombin inhibitor, dabigatran. Okay, dabigatran. This drug has an antidote called idarosizumab. So basically, collectively, these two drugs are called DOACs. Though drugs are in the DOACs, factor 10 and factor 2 inhibitors. Now, since we all got this, coming to the injections. In the injection, we got direct drugs and indirect. In the indirect, we got heparin, low molecular weight heparins, etc. Now, very high yield topic in pregnancy. Okay. Now, you must all keep in mind one very important thing here. And what is this important thing is, when you talk anticoagulants, first trimester, the best medications that we are going to use, okay, they are nothing but heparins. Okay, they are going to be known as heparins. Clear? This is about which trimester? First trimester. Second and third trimester, story is still the same. We still prefer heparins as medications. But if you want to use warfarin, we can only use warfarin in the second and the third trimester. Because warfarin is teratogenic, we cannot use it in the first trimester. It is teratogenic. It causes something called fetal warfarin syndrome. Okay, so we cannot use warfarin in the first trimester. Only if you want to use it in the second and third trimester. That too, heparin is usually the better option. Okay, and there is even certain guidelines like when to use warfarin. Warfarin can be used only in those pregnant women who are having mechanical valves in their heart if the dose of warfarin is less than 5. Okay, if the dose is less than 5 mg, that is the time when I can use this. If the dose is more than 5, then I should better use heparin. If a higher dose of warfarin is required, better go for heparin. Because of the risk of teratogenicity, it will increase. Okay. Now, since we have said this, hopefully you do not make any mistake in this. See, heparins means low molecular weight heparin, unfractioned heparin. So those are the drugs that we will generally go for. Okay. Now, since this section is over, let's move on. Okay. See, next part is this. greater than 36 weeks again, we should switch back to heparin again. So all the time heparin is there. Why warfarin shouldn't be used? Because warfarin causes bleeding in the baby. Okay. So warfarin ka dose only if it is less than 5 mg per day, you can use it. As I told you, if it is more than 5 mg, better go for heparin. And even after 36 weeks, heparin should be used. Discontinue warfarin if you were using it because it causes bleeding in the baby. Okay, so that's it. Best drugs ka kahani khatam. They love to ask this so many times. They have already asked. Next part is general pharmacology aspects. One of the most important things. Please revise the formulas from the notes. For example, what is VD? VD is equal to D by C. What is the formula of maintenance dose, loading dose, half-life? So 4 to 5 formulas are there. Please revise from the notes. Now I'm going to focus on this aspect, what we call as dose response curve. Now when we talk about dose response curve, what is the idea here? In this area response, in this area dose, concentration is there. Okay. This dose can also be called as Km. Okay, K for concentration. Response can be called as Vmax. So if you want to check the effect of a drug, which is known as efficacy, efficacy is also known as Vmax or effect, always look at the height in the graph. And if you want to check the potency, okay, potency is related to dose of a drug. Now, when I say a drug is having high potency drug will require less dose and a low potency drug will require high dose. So this is the logic right here. Okay, less dose and the high dose. So Abhi, if you check this picture, which is the drug having highest potency in this? Answer is A, because this might be 0 mg. Starting at this point, this is 0 mg. And if you move here, this might be 10 mg, this might be 20 mg, this might be 100 mg, like that. So I am saying which is the drug requiring very less dose in this? It is drug A. So this is the drug called high potency drug. Can I say high potency drugs will be on the left side of the graph? Yes. Left side will have high potency drugs. Right side will have low potency because they are requiring more dose. So low potency drugs are located on the right side of the graph. Now the effect. If the question examiner asks you which drug has highest effect, see, I think there is a slight change in the graph. Now according to this graph, if you see slight difference also, then this drug is having little more effect. If you notice, slightly compared to this, it's having little more effect. But what I wanted to teach you is, imagine these two are of the same height. Many students make this mistake in exam, so I want you to correct it right now. If you are having same height of two drugs, they are same effect only, meaning they both have equal efficacy. So according to this picture, as of now, what you're able to see, they will have maximum efficacy. Which are the two drugs which are clinically having more effect? Answer is A also, C also. Both are equally effective in treating the disease. Only dose is different. One drug requires 10 mg to treat that disease. One drug will require 100 mg to treat that disease, but the effect will stay the same. Okay, so that's all. Now since we have gotten this, drug B is called least effective drug because the height is less. This becomes the less. Okay. Now since we have gotten this, let's move on. Here we are. Sometimes they may ask you this topic called competitive inhibition and non-competitive inhibition. So what is competitive inhibition? Let's remember, how will the graph look like? Imagine earlier you used to produce the effect at 5 mg. That means this drug was very potent. So this is before the antagonist came into picture. Now when there is competition, if two guys are fighting to bind to the same site, what will happen? Same dose will not work. Okay, you have to have more dose to overcome the competitor. Are you understanding? Earlier you were alone, 5 mg enough. You are the only one binding to the receptor. But if there is a competition now, what will happen? You have to give more dose to overcome. So when you give more dose instead of 5 mg, now let's say to overcome the competitor, you require how much dose? Now you require 500 mg. So what happens after the antagonist comes into picture? You will have to give more dose to win. That means there is a shift from left to right. What did I teach you happens if you move from left to right? Potency decreases. In this graph itself, I told you now, right side pe you have low potency drugs. So in competitive inhibition, what is happening, sir? You are getting this potency decrease. Km increases, dose requirement increases, potency decreases. First question, can you win in competition? Okay, in competition, can you win? The answer is yes. Okay, win is a question mark. Answer is yes, you can win. How can you win in a competition? By running more kilometer. Think of it like that. I can win in competitive inhibition by increasing the dose. Dose is also called as Km. Okay. Next, you will see this in biochemistry. There is something called Lineweaver Burke plot. Lineweaver-Burke plot. So what do you need to know? Just a simple mnemonic. If two lines cross, meaning competitors cross each other, C for cross, C for competitive inhibition. No crossing, they don't cross, then that is called non-competitive inhibition. Non-competitive inhibition. And you must also know, like in the non-competitive inhibition, how will this graph look like? Sir, the idea is like this. This is before the agonist. The effect is more before the agonist. Next is after the agonist. After the agonist, the effect will decrease. So in non-competitive inhibition, okay, efficacy decreases. That is Vmax decreases. Okay. So I hope this is all clear for all of you. Efficacy decreases. Clear enough? So ye graphs very high yield hai boss. Now coming to respiratory and GIT pharmacology. So basically you got H. pylori here. You must keep in mind how to treat H. pylori. You got these things called triple N quadruple regimen. What is triple regimen? 2 antibiotics plus 1 PPI. Quadruple is same triple regimen along with one extra drug called bismuth. Now what is the things you got to remember? In the triple regimen, we got two regimens called OCA or OCM. What is this? O for the drug, omeprazole. Okay, O for omeprazole. Next, C for the drug, clarithromycin. M for the drug, metronidazole or amoxicillin. So either you can use OCA or you can use OCM. Are you understanding that? Now, some people may have clarithromycin resistance. That means some people clarithromycin will not work. If clarithromycin doesn't work, I cannot use OCA, I cannot use OCM. Are you understanding that? So if there is clarithromycin resistance, then what should I do? I should go for the quadruple regimen. Because what is quadruple regimen? In quadruple regimen, there is no clarithromycin. There is something called OBMT regimen. What is OBMT regimen? O for omeprazole, M for same metronidazole. Now instead of clarithromycin, you got a new antibiotic in this called tetracycline. ठीक है? So tetra means 4, quadra means 4. In quadruple we add tetra, quadra, tetra. Okay. Next, as usual, I think this you know, bismuth. Finished. Only if clarithrol does not work, then I'm gonna go for OBMT. Is that clear enough? So this is the logic, triple versus quadruple regimen. Next, this vomitings, I've already talked about this. Early onset vomiting means less than 1 day of starting chemo. If you vomit, then I'll give you citrons. More than 1 day late onset, then I'm going to give you the drugs called pitants. Okay, these are the drugs known as pitants. So simply remember late word pitai. If you come late to class, you're going to get pitai. Pitai means beating, right? So pitants are the drugs for late onset. Now, since this part is done, respiratory, you got asthma treatment. So if you look at asthma treatment, get an idea. Sir, obviously in the asthma treatment, the mainstay is steroids. We are going to see that. And bronchodilators as symptomatic treatment. Next, what else do we got here? Okay. IgE blocker. IgE blocker is called omalizumab. Okay, omalizumab. Next, IL-5 will be important for calling the eosinophils. You must remember number 5 is the 5th letter, eosinophil. Okay, eosinophils. So what I'm saying here is this. Sir, there is a new class of asthma now called eosinophilic asthma. So that's where we can use these drugs, mepolizumab, racilizumab, benralizumab, etc. So this is the pattern of the drug, lizumabs. Okay. So my bad respiratory system, you got to remember. That's where if your respiratory system has become bad, you're getting asthma, you got to use this one. All right. So now since this is done, coming to the steroids. So doctors, when it comes to steroids, they are the mainstay of the treatment. Please remember, if you use steroids, immunity reduces. You may get oropharyngeal candida. Why are you getting oropharyngeal candida? Because of taking the drugs from the mouth. How to prevent it? Prevention is pretty straightforward. Gargle after you take the medicines and use certain things called spacers. Okay, there are certain devices that I told you in the class, they're called spacers. Next, how do you treat it if it has happened already? You can go for a medicine called cotrimazole. You get cotrimazole in different forms. Topical means you can take either lozenges or you can take the paint. So different situations you can use the drug called cotrimazole. Finished. Now since we have said this is one-liners like which asthma, which drugs should be given. Okay. IgE antibody causes allergy, so we'll give omalizumab. Eosinophils, I told you, my bad respiratory system, that one. So this is it. Now since we have said that, there are certain guidelines called as GINA guidelines. Pretty straightforward. See, how to remember the GINA guidelines. If you see when you start the treatment of asthma, I am going to use low dose of steroids. Okay, low dose steroid along with formoterol. So basically it is low dose of steroids. Then let's say this is not enough. So when do you say it's not enough? It's written here, like when do you say it's not enough? This is although a topic of medicine, but still I'm just covering these guidelines quickly here. Sir, if this is not enough, be logical enough. Steroids are the main drugs. Increase the dose of steroids from from low dose to medium dose. They have become now medium dose. Next, after this, what if even this is not enough? Then increase the dose to high dose ICS along with formoterol. ये तो हमेशा रहेगा. Bronchodilator called formoterol because it is fast also, long also. That's why we use formoterol. along with steroids. First low dose, next medium dose, next high dose. Now along with these drugs, we will add more drugs if needed, like IgE blocker, etc., etc., IL-5 blocker. These are the simple GINA guidelines. Okay. Next is the topic called antibiotics. Although we may not like it, but this is super, super important. So guys, when it comes to antibiotics, first thing is leprosy. Leprosy, we give the treatment called DRC. Mild leprosy, we give it for 6 months. Severe leprosy, we give it for 12 months. Remember the sequence DRC, please. Okay. Now let's look at something. How do you give this DRC? So there is a kit that comes, you must have seen even in your PSM, etc. So what is the story? Now you check this out. Today, if I'm starting the kit, the first day I'll be taking 3 drugs, DRC. D is the first letter in my mnemonic, only one drug. R is the second word, 2 drugs. C is the third word, so 3 drugs. Look at the dosing. Next, this is given only once a month. Rifampicin is given only once a month, monthly. We don't give rifampicin after this. Only first day of the month you give this. Which drugs are continued later? Dapsone and clofazimine is continued. Now, check this. Dapsone ka dose, when you start 100 mg, later on also 100 mg. No change. Clofazimine initially 100 mg, later half the dose 50 mg. This is what you're going to do. And as you see, rifampicin, it is, only given once a month, as I told you. Okay, so total how much rifampicin? 600 mg, because 300 mg into 2. Okay, so now since we have said this, we can move further. Okay, now here we go. There is a drug called clofazimine which we learned. It causes skin darkening called hyperpigmentation, and another thing called ichthyosis. You must be knowing from dermatology how it looks like. So this was about the guy called, leprosy. Next is TB treatment. If you see the TB treatment here, we got 4 drugs, HRZE. Now when you learn the TB drugs, always first focus on the side effects of TB drugs. Okay. For example, isoniazid, what does it do? Isoniazid, it reduces vitamin B6 as a side effect. It reduces pyridoxine, which leads to peripheral neuropathy and an anemia called sideroblastic anemia. Sideroblastic anemia. We know this is the drug isoniazid that comes in ship also, right? So it causes SLE. And it comes in disco mnemonic, which causes gynecomastia. So both the things are here. Rifampicin, you got to remember every R here. Rifampicin, it's a RNA inhibitor. It is having a mutation RPOB gene, then rifampicin will not work, and it causes red to orange color secretions. Now, something what I have given you earlier in our main notes, please check that. What is the definition of MDR-TB, pre-XDR-TB and XDR-TB? You must know the definitions of that, and the new treatment I told you for the MDR-TB called BPAM. BPAM regimen is bedaquiline, retomanid, linezolid and moxifloxacin. Those 4 drugs you got to know for BPAM regimen. Next is something called pyrazinamide. It causes hyperuricemia. And eye-related side effects you must know with ethambutol. Okay, eye-related side effects with ethambutol. Next, rifampicin, it increases the enzymes of metabolism. If more enzymes are metabolizing the drugs, what will happen? It leads to drug failures. It leads to drug failures. Some important drugs it may fail are OCP, warfarin, dolutegravir, etc. Dolutegravir is a drug we use in HIV. I'm going to teach you in some time. Please remember, if the patient is having dolutegravir in the treatment of HIV, dolutegravir mein we need to double the dose. Okay, we need to double the dose. Okay, dole hote hai na, dole are 2. So please remember, we need to double the dose. Now, since we said that, imagine if a patient is diagnosed with HIV and TB. HIV treatment is called ART, antiretroviral treatment. Okay, HIV treatment is called as ART, hai na? So you must remember this. At least you should keep a gap of 2 weeks. First, who should you start always? TB treatment. Okay. First, you should start the TB treatment. Next, you must go for what? The HIV treatment. Is that understood? So now that we have said this, if the CD4 count is so and so, what to do? It is written clearly here. Otherwise, there is a risk of something called iris syndrome. All right, iris syndrome. So usually at FMGE level, etc., they will ask you first give TB treatment followed by the HIV treatment. Okay. This is the logic here. Some gaps need to be maintained. Clinically, we have to divide them based on the CD4 count. If the patient's CD4 count is very less than 50, he is almost anyway dying now. So what do? Don't wait for more than 2 weeks. Rather, you will start it within 2 weeks. Okay. Let's say the CD4 count is slightly better, more than 50 it is there. Then you can give a gap of at least 2 weeks to reduce that risk of iris. TB meningitis, again give a gap of more than 2 weeks. Okay, so this is the logics that we need to keep in mind so far. Next is ART. ART means antiretroviral treatment. What is the treatment? Okay, first, imagine there is a spouse of a person having HIV. So there is a person having HIV, he has a wife or a husband, he or she. That other person is at risk of getting HIV by sex, yes or no? So what we can do, give a drug to that spouse so that they don't get it. So the drug that we can give is called T plus E. Or the newer drugs that have come recently are called carbotegravir, which is a very long-acting drug, or lenacapavir. These are the newer drugs that has been approved for pre-exposure prophylaxis. That means before you are even exposed, we can take this. High-risk individuals are given pre-exposure prophylaxis. Next is anybody who got exposed to HIV. Let's say we as doctors, we got needle stick injury. Now I'm exposed to HIV. What can I do? Start taking the drugs of HIV within 3 days, maximum within 3 days. Okay, the early you start, the better. And you have to take it for approx 1 month, that is 28 days. What are the drugs to be taken? TLD. I call it HIV limited. Remember it like a trademark. HIV limited, LTD. HIV limited is given for 28 days for the prevention. Same HIV limited is also given in the treatment. Okay, but this is lifelong. Lifelong HIV limited. Are you all understanding that? These are the drugs that you need to remember. Okay. Now, since we said this, last thing, what if the mother is having HIV? How can you prevent this from coming into the babies? First, the treatment will be given always to the baby after the baby is born, and this will be continued for, durations I'll teach you. The drugs will be given in the form of syrups. Okay, the baby will receive this in the form of syrup. Now, two situations. Mother is already on the treatment or mother is not on the HIV treatment. Obviously, if the mother is already taking HIV drugs, risk of HIV is less in the baby. So we give a drug called nevirapine. into 6 weeks. That means after the baby is born, we give nevirapine to the baby. Next, what if the mother is not taking the treatment? If the mother is not on treatment, baby has high risk of getting HIV. So you give 2 drugs now, nevirapine plus zidovudine. Further, we can segregate this. Without breastfeed, meaning if the mother is not breastfeeding the baby, risk of HIV is less. Give this 2 drugs for 6 weeks. This drugs has to be given for 6 weeks. But if the mother is breastfeeding, there is higher risk of HIV, then how do you give this? 12 weeks. So what did we say? Mother is not on any treatment, then divide this with breastfeeding or without breastfeeding. Accordingly, you have to decide. Maximum risk is mom is not on HIV drugs and she is going to breastfeed the baby. Highest risk to get HIV. That's where 2 drugs given for 12 weeks. That means 3 months I have to give. For the other 1.5 months. Last and the final, there are some drugs which have action against both HIV also, hepatitis B also. Okay, hepatitis B also. So you must remember them by the mnemonic, tell me the drugs. Tell me the drugs of hepatitis B and HIV. That means these are the drugs which have action even in hepatitis B. But if they ask you hepatitis B, what is the drug of choice? Then you should be saying tenofovir. Tenofovir is the drug of choice for hepatitis B. And this is originally a drug from HIV topic. If you check HIV limited topic, lamivudine, tenofovir, these are the drugs which are actually used in, HIV. Now, since we have said this, antifungals. So you must keep in mind kiski kaun si drug hai. This is a pure memorization topic. Fluconazole will be used for candida. It's also used for cryptococcal meningitis, but the main treatment of choice for cryptococcal meningitis is amphotericin B plus flucytosine. Okay. Next, voriconazole. It is used for aspergillus. Voriconazole for aspergillus. This is the drug people from our class will know for sure. Next thing, okay, nail lacquer means these are nail paints. So they're given for onychomycosis. Okay, they're used in the treatment of onychomycosis. Onychomycosis means nail infection. If you're having nail infection, these are the 4 drugs. C8 is the name. C8 tires how you get. Next, moving further, you got this worms as the topic. If you see the worms, I'll give you one simple hint. Say it is a lag. Okay, so looks like I guess it is back now. We are almost there. Okay. So tell me if you're back. 1 minute, I think it lags somewhere in between and then it comes back. So it should be back by now. When I see all your text, so many people texting, then I stop. I didn't teach anything after that. Okay. It is like a lucid interval that we are getting. Somewhere in between it happens, then it goes back. So nothing fancy. Look at the worms. This is the worms that I was teaching you. Sir, my word is platyhelminths are flatworms. P for P, the drug to be used for them is praziquantel. Exceptions are given already for fasciola, triclabendazole, hydatid cyst disease, etc. Albendazole. Albendazole. Done. Nematodes are called roundworms. For the roundworms, we give albendazole. Okay. Albendazole, this is the one that you need to know. Please remember, albendazole has the word azole, right? So you should remember azole is round. Okay, I don't need to tell you, you know that azole is round. So there are some azoles in the form of humans also sometimes. Now you can check this. Malaria treatment. Malaria treatment, the last one. Pretty much we are sorted. Iske baad session will end. So malaria treatment, if you check this out, we must keep in mind Vivax and falciparum. Vivax and falciparum, how do you treat? So I told you guys a mnemonic earlier, very cool fact. Okay, very cool fact. So this is the mnemonic that you got to remember, very cool fact. That means for Vivax, the drug of choice is chloroquine, and in pregnancy also same drug chloroquine is given. Okay, plus we will be giving a drug called primaquine for 14 days. I mean, not in this. This is in the normal people. Chloroquine, because there was space, I was writing this. Better not to confuse you. Primaquine for 14 days. So treatment of Vivax will be chloroquine plus primaquine for 14 days. Chloroquine 3 days, primaquine 14 days. Primaquine is contraindicated in pregnancy. We cannot give primaquine in pregnancy. Okay. Next is, what about falciparum? For falciparum, we need to give ACT for the word fact. Then we may add one drug called primaquine on day 2. On the second day, we give one single dose of primaquine. It is written below here. Okay, in the falci, we give 0.75 mg of primaquine on the day 2. Okay, I think there's a misprint. It's usually given on the day 2. Okay, so now since we have said this, let's move on. What about falciparum? Okay, quinine plus clindamycin for 7 days. Okay, quinine plus clindamycin for 7 days. That is what is the main thing as of now in the Indian guidelines. There's a new update that has come which says in WHO guidelines now we can give actually ACT even in all the 3 trimester. पहले से ही second and third trimester we could give ACT. We were avoiding ACT in the first trimester. New guidelines say ACT can be used in all the 3 trimester. They have made it more easier for us to teach. Chloroquine all the 3 trimester. Same way now they are saying ACT in all the 3. Unless they specifically mention WHO guidelines, don't answer this. Are you understanding that? What do you answer according to the current guidelines? Quinine and clindamycin in the first trimester and second and third ACT. Second and third trimester ACT. Okay, that's all about this. So ye kahani khatam. Now, what do you do when it comes to ACT? I hope you guys know. By the way, if you are having severe malaria, first you give IV artesunate followed by the oral ACT. So this you must have revised in other subjects, but just reminding you, what is the ACT to be followed for falci? Treatment of falci. It is known as ACT. This ACT will be divided into 2 types. Okay, what and what? If you're talking most India, most of the states in India, we give the treatment called ASP. ASP stands for artesunate plus sulfadoxine plus pyrimethamine. This you will find in our main notes also, and I hope you have memorized this already. And the northeastern states of India, we give the treatment called AL treatment. What is AL? Artemether plus lumefantrine. This one, artemether plus lumefantrine, the one which we give in Northeast. Now they are saying same treatment we can give even in pregnancy. Okay, so Now, since we have said all of these things here, as I told you, these are some list of the things that we have here. This I will fill it up and share it with you later on. Okay, so this actually ends up your the revision session of pharmacology. Roughly speaking, 3.5 hours that we took for this, the minimum time that is required. All right, friends. So as I told you, post this, we'll be doing some questions. Okay, I will do the questions. If you guys are tired, you can watch this later on. Anyway, if there is lag, etc., you can just skip that part and quickly go about it. All right, but let me do some questions at least so that you guys get to know this. Okay, and anyway, like after this is done, many important things we have covered. All right, so I want your good words in the comments. That should be our booster, our energy, that our hard work also you guys are appreciating. It's a mutual thing, and we should specifically thank Dr. Bhanu sir, okay, for giving you guys such a wonderful platform where you're able to revise all these things importantly, and even for us to come up and teach you guys whatever that is there before the exam. So definitely he deserves that praise and respect. Dr. Bhanu sir, definitely you should message him also. I would like that even in the comment box. Thank you, Bhanu sir. I want that at least 100 people should do that. Make him also feel that yes, what he is doing for the community, it is good. Okay, so kahani khatam. Next thing, in a minute I'm going to come back. Let's solve some MCQs before you guys go to sleep. Okay, all right, so here we are, some questions. Chalo karte hain. So here we are. The first thing is, these are the questions from the ANS topic. See, if I wait one minute for everybody to answer, it's going to take a long time. You guys pause the video, quickly read the question on your own and answer. I'm going to quickly run through the questions, tell you the answers exactly why they are the answers. Okay, otherwise it's going to take a lot of time, because it's not only FMG questions, NEET PG is also there, INI set is also there. So that's why I'm telling you that this will take a lot of time, and I will not be able to give you that time that if you're expecting right now. Okay, so we will get started here. All right, chalo. So as I told you, before we get started, I also will take like 2-3 minutes break for my voice, then I will get started. Okay. Okay, folks, so let's get started. Dr. Naveen, our blessings are always with you guys. We are here together so that our hard work is getting blessed soon enough. Just wait for the good time. All of you hopefully will return to me with the good messages that, sir, we passed this exam. Okay, waiting for that message from all of you. So that's where I had given you my Insta earlier. Chalo, let's start. This was a recent exam question, January 2025. That means the last exam that just happened. All right. Young boy brought to the ER after accidental ingestion of unknown medication. He presents with palpitation, dry mouth, mydriasis, and tachycardia. Mydriasis, I told you, could be cocaine, could be anticholinergic, things like bad. So basically, mydriasis, I saw, etc., dry mouth, this is bad. Either it's belladonna, atropine, or datura. What is the antidote for this? The antidote for these things is none other than physostigmine. Yes or no? So the antidote here is going to be physostigmine. Next is this question. As you can see the headings, I will not read out every time. This was asked in the December exam again. So in OP poisoning, which of the effects cannot be reversed by atropine? This is a question we discussed already during explanation. I told you atropine is purely muscarinic blocker. It's a muscarinic blocker, so it cannot reverse the effects of nicotinic. So this has to be muscle weakness. Muscle weakness cannot be reversed. Okay. What is the mechanism of action of botulinum toxin? Botulinum toxin, it relaxes your muscles by blocking the release of acetylcholine. Acetylcholine. Okay. Next. In a patient after giving noradrenaline, the patient was noticed to have decrease in the heart rate. What could be the possible mechanism? Remember, I told you when you give noradrenaline, the BP increases, heart rate decreases. BP increases, heart rate decreases. Because of the increase in BP, the heart rate is decreasing. Opposite. You must have read in physiology, this is called baroreceptor reflex. Okay, this is called baroreceptor reflex. This is the correct answer here. Okay, stimulation of baroreceptors will send a signal, then the heart rate will reduce. Okay. Next, a patient was given anesthesia for surgery. Okay. Next, what is the drug used in the management of post-op muscle paralysis? Remember, B for bethanechol, B for bowel and bladder. I used to teach you like that in the class. So bethanechol is the drug that we use for the treatment of post-operative ileus. Okay. Next is, what is the drug used for the treatment, drug used for myasthenia diagnosis? Test for myasthenia. They're not asking treatment. Test means it is tensilon test. Answer got to be edrophonium. Edrophonium. Okay. Isoprenaline. Isoprenaline, I told you, is a drug that increases heart rate, but it reduces BP. So the most appropriate answer for this got to be this. Isoprenaline decreases heart rate, decreases BP, increases heart rate. Remember in the notes earlier, we saw that graphs. So this is the question. A patient was admitted with complaints of tachycardia and arrhythmia. Physical exam shows stretch marks over the body. Which of the following is the patient most likely abusing? Okay. Here the answer will be cocaine. Scratch marks over the body. You all must be knowing that cocaine patients feel insects crawling on the skin, tactile hallucinations, Magnan symptoms, yes or no, cocaine bugs, whatever you remember. So that's why it is this. I told you cocaine increases sympathetic activity. That's why you're getting tachycardia also. So that's why this should be the answer here. Next, a patient presented with ptosis that gets worse by evening. He was diagnosed with myasthenia gravis. What is the preferred drug for this case? So if you talk about the treatment of myasthenia, pyridostigmine is the treatment. So you have seen already so many questions on myasthenia has been asked. Okay, so don't miss concept, same, just the graph has been given, repeated question, right? So in this graph, what you and I are able to see is that the pulse rate is going down, meaning heart rate is going down, but BP is increasing. That means it got to be the baroreceptor reflex. Okay, it is the baroreceptor reflex. That's it. Next, we continue. The drug of choice for ADHD, methylphenidate. Direct question. Drug of choice is methylphenidate. Guys, I understand I'm going faster in this. I told you, you pause the video. It's a YouTube video. You can pause when I start a question. You answer, then you look at the correct answer. Okay, that's how it's going to go. Otherwise, so many questions, it will take time. Which of the following leads to acute hepatic failure? If you're talking acute hepatic failure, then there is this mushroom poisoning called Amanita phalloides. Amanita phalloides, this is the one that leads to hepatic failure. And unfortunately, we don't have a great treatment for this mushroom poisoning. There are some mushroom poisonings that we can treat, but not this one. Okay. Next. So Jan 2023. So I told you from 2025 till 2023, we are having all the questions here. A patient with pheochromocytoma is planned for a surgery. Which drug should be started pre-operatively? Then here the answer got to be phenoxybenzamine. Do you remember that big name, pheochromocytoma? Then you will be saying big name of the drug, phenoxybenzamine. Next is a patient develops hypertensive crisis after consuming cheese while on MAO inhibitors. Drug of choice for the treatment. So basically they are talking cheese reaction. Drug of choice तो आपको fingertips पे होना चाहिए. Phentolamine is the answer for this. Phentolamine is the treatment for this. Next, preferred cycloplegic for pediatric refraction. Usually when you talk about children, we must all know there is a drug that we use called atropine. Why? Because it is a strong cycloplegic. It's a strong cycloplegic medicine. That is what is going to be used. Okay. Next one, if you see here, the question is a 42-year-old man presents with headache, palpitation, hypertension. Imaging confirms he has an adrenal mass. Already the answer is there. Which drug is given to control the blood pressure in this patient? Again, the same situation. Answer will be phenoxybenzamine. Okay. So again, we had a couple of times question on pheochromocytoma. That topic need to be read well. So I'm reminding you how the questions are framed from the previous topics. Okay. Coming to a little higher level, NEET PG. So a patient was found in an alley with hot, dry skin. Okay, raised temperature, dilated pupil means mydriasis, staggering gait. Which of the following is most likely cause? Okay, so if you see dryness, opposite of dumbbells, na? Dilated pupils. So when there is opposite of dumbbells, you also get hypothermia. So that is the reason the answer is datura poisoning. Belladonna, atropine, datura, they can cause even increase in the temperature. Okay, bad. So this is done. Next is which of the following is the most appropriate treatment for the overactive bladder in a patient with dementia? In a patient with dementia. All right. Now that you see here, obviously I will not be able to use ipratropium because that's a bronchodilator. It's not used for this thing. Tiotropium, ipratropium, they are bronchodilators. Telenzapeine is used for GIT. It reduces acidity. It's used for GIT issue. So from the soft bladder, I am left with tolterodine. Although this is not the best, we can use this tolterodine, but the best drug is trospium. Okay, so if this question is there, in my opinion, the best answer got to be trospium. But they have not given this option in the real exam. That's why even I didn't put this. Okay. Now next question is 42-year-old drug addict presents to the emergency department with signs of unknown drug poisoning. Patient exhibits dilated pupils, diaphoresis, tachycardia, tremors, blood pressure is so and so, heart rate is so and so. What is the most likely diagnosis? Okay, so now that we have seen this, this is an older question only that we have seen. So let us move further. NEET PG 2023, last 2 years back. Patient with OP poisoning is treated with IV atropine and pralidoxim, suddenly develops fever after 2 hours. What is the cause? See, what does atropine do? Atropine blocks muscarinic receptor. In other words, atropine will block sweating, because on the sweat glands, what is present? On the sweat glands, muscarinic receptor is present. If sweating is blocked, obviously your temperature will increase. So that's why belladonna, atropine, datura, they can all cause hyperthermia. Okay, hope that is all clear to everybody. Okay. Next is, a child consumes an unknown fruit and develops abnormal behavior, fever, and decreased urine output. Identify the fruit and the appropriate treatment. Once again, datura, the antidote is physostigmine. Okay, physostigmine. तो भाई रट लो, datura, belladonna, physostigmine, all these things had so many questions already, right? So you're getting an idea, these topics should not be left. This is INI set November 2025, that means just a recent exam question. Curve A represent acetylcholine. That means they are saying that this represents acetylcholine alone in the dose response curve. Which is drug B in the curve? So they are asking which drug from the 4 options could be drug B. Sir, first of all, after giving drug B, the effect of acetylcholine is increasing. Are you understanding? It's not decreasing. It is increasing. After giving drug, if acetylcholine effect is increasing, don't you think that guy increases acetylcholine? Natural acetylcholine is there in the body. After giving the drug, acetylcholine ka effect is increasing. That means the other drug must be increasing acetylcholine. So which of the drug from the list increases acetylcholine? Logically, the answer got to be physostigmine. Physostigmine kya karta hai? What does physostigmine do? It blocks acetylcholinesterase enzyme. It will increase acetylcholine. That's why the B has to be physostigmine. That's it. Adrenaline is sympathetic. Atropine blocks acetylcholine receptor called muscarinic. So that's it. The correct answer is physostigmine. Got it? हो गया, ANS khatam. Next is CNS. So if you talk about CNS, the recent FMGE exam question hai. Patient with schizophrenia developed muscle dystonia and was given the treatment for that. He presents with complaints of dry mouth, mydriasis, urinary retention. Which of the following is most likely responsible for this symptoms? Sir, did I teach you? Schizophrenia means psychosis. We give antipsychotics like haloperidol, risperidone, which can cause EPS. Muscular dystonia, I told you, torticollis, etc. can happen. Now, for that torticollis, what is the drug that is given? Benzhexol, benztropine. Yes or no? We have to give benzhexol or benztropine. Sir, benzhexol or benztropine, they are muscarinic blockers. Okay, they are muscarinic blockers. Muscarinic blockers means they will produce opposite of dumbbells. What is opposite of dumbbells? Dry mouth, mydriasis, urinary retention. That means all the symptoms are a side effect of benztropine. Question फिर से देखो. Haloperidol or risperidone produces the first side effect. What is the side effect? Muscular dystonia. You're getting torticollis. Now for the torticollis, you gave a treatment. What is the treatment you gave, sir? You gave a treatment called as benztropine benzhexol. Benztropine benzhexol are doing some side effects now. What are the side effects? Dry mouth, etc., etc. This is the question that they have twisted. Usually they ask who causes it or what is the treatment. Now they asked what is the side effect. Okay. Next question. 40-year-old male is brought to ER after being found unconscious at home. On examination, he is unresponsive, pinpoint pupil, weak pulse. Sir, buzzword, pinpoint pupil. Pinpoint bolte hi, what did I teach you? Either OP or opioids. It doesn't look like a farmer. Respiratory depression is there. That means it's a opioid poisoning. What is the antidote of opioid poisoning? Naloxone. Naloxone. ठीक है? I hope you guys are getting this. I'm really surprised you guys are answering when I'm not even giving you time for this. I can see your options. Makes me proud. Awesome, guys. Awesome. So, next question. A woman presents with galactorrhea and amenorrhea. MRI reveals a pituitary macroadenoma compressing the optic chiasm. What is the drug of choice to manage the patient? So, patient is having galactorrhea, amenorrhea. That means these are the features of what? These are the features of hyperprolactinemia. Question is asking how will you treat hyperprolactinemia? The answer is bromocriptine or cabergoline. Remember we saw this? Ergots, rods, fingers. That one. Next question. An infant presents with seizure. Diagnosis of infantile spasm is made. Which is the drug preferred in the management? ACTH. Salam seizure. Remember infantile spasm, ACTH. Vigabatrin will be only answered as the drug if they give tuberous sclerosis. Okay. Next. A patient undergoing surgery is administered succinylcholine and his body temperature goes up. You must know this from anesthesia topic, and anyway I teach in my pharma class also. Succinylcholine and halothane. What do? They do this thing called malignant hyperthermia. Malignant hyperthermia. This is by the drugs like halothane or succinylcholine. When you get this halothane or succinylcholine induced malignant hyperthermia or antipsychotics, what they do? Treatment is same. What is the treatment for both of them? Answer is dantrolene. What is dantrolene? It relaxes your muscles by working on something called ryanodine receptor. It's a ryanodine receptor blocker. Okay, it's a ryanodine receptor blocker. Patient has some visual defects after consuming a drink. Which substance may be responsible for this? So when you drink methanol, the metabolites of methanol makes you blind, and that metabolite is called formic acid. So formic acid is the one that kills you. Make sure you remember this. It kills you and makes you blind. Next question. 30-year-old male undergoing treatment of seizure, having gum hypertrophy and vitamin B12 deficiency. Which of the following might be the patient on? Okay. Sir, gum hypertrophy, etc. is the buzzwords. Vitamin B12 deficiency. It is phenytoin. Phenytoin reduces B12, vitamin K, etc., etc. A psychotic patient was started on olanzapine therapy. Olanzapine carries maximum risk of which of the following side effects? Weight gain. Okay. Wet pillow syndrome, agranulocytosis are the side effects of clozapine. Clozapine. Okay. Ola, if you take, you will gain weight. Remember? Next, a patient on metronidazole therapy went to a party, consumed alcohol, after which developed so and so symptoms. Which is the most likely diagnosis? Disulfiram reaction. Alcohol, metronidazole, two words. Remember, I told you disulfiram, there is a drug that punishes you if you drink alcohol. Then I told you there are drugs that copy that. What are they called? MCC, metronidazole, cephalosporin, etc. What is the mechanism of action of ethosuximide? The answer is blocks calcium channels. Ethosuximide is used in absence seizure, but if you have absence seizure plus something else, you should go for valproate. Mechanism of action of local anesthetics. Local anesthetics, they block sodium channels. If you block sodium channel, no depolarization. If there is no depolarization, no sensation. Okay. Next, which of the following is given to prevent NTD? I know this you will say even in your sleep. I won't even wait. Vitamin B12. Okay. B12. That's what is given to prevent NTD. Sorry, not B12. B9. B9 is your folate. Folate is B9. Is that understood? By mistake, I said B12. Next, what is the drug of choice for delirium? Delirium due to alcohol, they have asked in the question. Delirium due to alcohol, then the answer will be lorazepam. Okay, lorazepam, even though haloperidol can also be used. Okay. Next, this is December 2023. That means 2 years back. Again, same EPS. See, I'm going chapter wise. Now we are in the CNS now. You're already getting an idea what they have asked so many times. Sir, you took haloperidol, you got muscular dystonia. What is the treatment? Treatment got to be benztropine benzhexol. Now do you understand the emphasis? Okay. 3-year-old child with GTCS presents with convulsions for more than 45 minutes. What is the appropriate treatment? Okay, what is the appropriate treatment here? Now, you must keep an idea that the best option here will be this. Please remember, many of you must be thinking valproate as the answer because you saw GTCS. Why B is the answer here? I told you just like valproate, levetiracetam, etc. also is a very good drug. Okay, but why B is the correct answer? Because they have mentioned status epilepticus more than 5 minutes. Since it is status epilepticus, I need to first give you a drug that calms you down like lorazepam. Always remember, in the seizure time, the first drug to be given is lorazepam only. Only if epilepsy is diagnosed, then you will give other drugs. Okay, always remember. That's why the answer is this. GTCS will be taken care by levetiracetam or valproate. Okay, but for the status epilepticus, we need to give you a sedative like lorazepam. Okay. Next, moving on. Amongst the antipsychotic, which has least chances of weight gain? Which guy has least chances of weight gain? My class people will answer A to Z. If you walk, obviously you will lose weight. I mean, they don't cause weight gain. Patient was given bupivacaine, after which developed toxicity. How do you treat this toxicity of canes? Fat sponge, fat sponge. Do you remember this? This is 20% intralipid. I told you it absorbs the lipophilic molecules of anesthetic drugs and traps them. This is called as 20% intralipid. It is called lipid sink mechanism. Sink means, basin, wash basin. It takes them inside. It's like that. Next one, a chronic alcoholic presents with confusion, ophthalmoplegia and ataxia. Which vitamin deficiency is this? Come on, easy one. Alcoholic bolte hi, your brain should say something. Thiamine deficiency. Thiamine deficiency, yes or no? So thiamine deficiency people get something called Wernicke's-Korsakoff psychosis also. Wernicke's-Korsakoff syndrome. So Wernicke's encephalopathy, and the other thing is confabulation, etc. Yes or no? Next, a patient with benzodiazepine overdose presents to the emergency department. What is the specific antidote? Okay, what is the specific antidote? So the antidote here is flumazenil. Okay, benzodiazepine ka antidote we have already learned, it is flumazenil, benzmethylmazet. All are the SSRIs used in depression except. Answer is trazodone. Some of you will argue, sir, trazodone is also antidepressant. Read the question. They said SSRIs. Trazodone is a atypical antidepressant. It is a atypical antidepressant. It is not a SSRI. Remaining three options are all SSRIs. Okay. Next. Consumption of spurious liquor causes blurred vision and ataxia. Antidote is. So if you check this, the antidote here got to be ethyl alcohol. Ethyl alcohol. Long-term therapy, lithium therapy causes all except. And in the lithium mnemonic, T for tremors is there. It's not tardive dyskinesia. Or if you remember EPS. EPS are the side effects of antipsychotics. It's not a side effect of lithium. Okay, that's why the answer is this. Patient develops hypertensive episode after wine intake. Safest antidepressant is. Okay, so now if you see this, we cannot give, MAO inhibitors, etc. So if at all we have to choose an answer, then that will be SSRIs. Okay, so next thing is 6-year-old boy is brought to the ER with seizure having high grade fever. Just a recent MCQ NEET PG. Okay, so high grade fever, what is the most appropriate immediate treatment for this child? So child is there, seizure is there, fever word, it is nothing but febrile seizure. So for febrile seizure, I'm gonna go for diazepam or intranasal midazolam. Diazepam or intranasal midazolam. I hope this is clear. 40-year-old woman with migraine was started on sumatriptan. She has no comorbidities but has positive family history of coronary artery disease. Migraine is there, coronary artery disease is there. She reports experiencing chest tightness after taking the medication, obviously triptans. Which of the following is an appropriate drug for the migraine prophylaxis in this patient? The correct answer to this is topiramate. Now the argument will come, sir, you said propranolol is the drug of choice. Yes, I said that. But pay attention here what is given. Do you know that non-selective beta blockers are avoided in vasospastic diseases? It is a question that is checking more knowledge. If you read the beta blocker topic, I have given you this loud and clear. I told beta blockers like propranolol are avoided in vasospastic diseases. That's why I will not be able to give you propranolol. I will give you topiramate. Okay? Chalo, yaad rakhenge isko. If this comes in real exam, don't make this mistake. I know all of you have memorized propranolol. Now, in case they give you this kind of a situation, topiramate. This is what I wanted, my friends, like, learn from this. Apart from the factual things that we have learned and understood, MCQs will put these facts more easily in the brain. Especially when you make mistakes, you will remember. I'm sure your mistakes also you remember. Next, sir. Man with schizophrenia on haloperidol therapy for the past 4 years. Presence with rabbit-like movements. Okay, presence with rabbit-like movements. So what is the most likely reason and appropriate treatment for this condition? Okay, so you must remember this is nothing but tardive dyskinesia treated by valbenzine. Valbenzine. Okay. Next question. Now, since we have said this, let's try to understand this. What are they asking in the question? So, patient developed flushing hypotension and bronchospasm. Which of the following is most likely responsible for this? Now, they're talking about the drugs called as skeletal muscle relaxants here. Now, you see there are two types of drugs in this options. One is curiums and another one is curoniums. In the curoniums, you will see the word on. They have a word on. Let's remember that word on as no. Just reverse it and remember no. Anybody having curonium has on. On means no. No histamine release. No histamine release. Are you understanding that? They don't cause histamine release. What does histamine do? Histamine causes vasodilation and bronchoconstriction. That vasodilation due to histamine. So histamine is causing hypotension due to vasodilation and histamine is causing bronchoconstriction. So it cannot be vecuronium, it cannot be pancuronium. Now if you know, atracurium has maximum histamine release. Okay, so this guy releases histamine. Histamine released by the drug called atracurium is doing all these things. Vecuronium, what you should know, this is the drug that is preferred in cardiac patients. Anesthesia, right? This is preferred in cardiac patients. Cis-atracurium is more safer drug. Okay, so this is a more safer drug compared to atracurium. Safer than atracurium. Better है ना ये? Sister है, more soft. ठीक है? This guy is 18 years old, 18. In 18 years, you get a lot of vasodilations in life. This is cis-atracurium. Sister is more safer than the brother. Okay. So now if you check this out, cis-atracurium is safer, and you must also remember something called Hoffman's elimination. Hoffman's elimination. Remember this thing? Okay. Because it is causing Hoffman's elimination, especially atracurium or cis-atracurium, this guys become safe in which things, sir? Renal failure, liver failure, etc. Okay, so safe in liver or kidney disease. Safe in liver or kidney disease. Pancuronium, it has vagolytic effects. So in fact, it will cause hypertension and not hypotension. Okay, so that's it. What is the correct answer in the end for this topic? The answer is atracurium. Atracurium. Okay. Next, general anesthetic sevoflurane and succinylcholine was given to somebody, blah blah blah, hyperthermia, succinylcholine. Have your diagnosis ready. You know this is nothing but malignant hyperthermia. What is the treatment that is given to this person? Answer, dantrolene. Okay. Next, a man on long-term hydrochlorothiazide presents with cerebellar ataxia, blah blah, non-motor peripheral neuropathy, right heart failure. No history of alcoholism is present. Which of the following deficiency were associated with this? Okay, so thiamine deficiency. Okay, thiamine deficiency. Next, most likely the question was supposed to be history of alcoholism is present. History of alcoholism is present. So what do you go for? Thiamine. Next thing is, a patient with mild renal failure requires reversal of muscle relaxant by vecuronium. Which of the following drug is the appropriate antidote? Now, you must remember all the curonium type of drugs. The antidote is known as neostigmine. General antidote for all the curoniums, it is neostigmine. But only for vecuronium or rocuronium. Vecuronium or rocuronium, the antidote is called Sugamadex. Okay, Sugamadex. Sugamadex is a specific antidote since they have mentioned what's a vecuronium. Okay. Next, a male with a history of chronic alcohol use is admitted to the hospital. He presents with anxiety, tremors, and is most appropriate to control the symptoms. I told you lorazepam. Alcohol withdrawal symptoms were given, so obviously I'm going to go for lorazepam. Okay, it's given last drink, meaning it's a withdrawal. Withdrawal mein what do you give? Lorazepam. What is the drug used for opium addiction maintenance therapy? That means you are an addict, you want to lose it, de-addict. What do you go for? Buprenorphine or methadone? Please don't answer naloxone. It's not a toxicity. They're asking opioid addiction. So buprenorphine or methadone is the answer. Which of the following is a SNRI used for the treatment? Okay, SNRI used for the treatment, if you talk about this, then we are talking ADHD. Normally, the drug of choice for ADHD is methylphenidate, but they are saying which SNRI? Methylphenidate is not a SNRI. Reboxetine. Okay, the answer here is reboxetine. Slightly more higher questions, na NEET PG INI set, they will be there. Okay, not everything will be direct. Next, a patient on long-term sertraline therapy. Sertraline is nothing but a SSRI, and patient was put on MAO inhibitor and amitriptyline. Amitriptyline is a TCA. He developed some symptoms. Which of the following is the most likely treatment? Combining two drugs that increases serotonin, you will get something called serotonin syndrome. Serotonin syndrome. Okay. So serotonin syndrome presents with this mental status changes. Okay. Agitation, disorientation, etc. It presents with fever, sweating, etc. That is also there, as well as tremors and all this. So we need to give you a serotonin blocker, and the name of the serotonin blocker is called cyproheptadine. So it's a serotonin blocker. It's an antidote for serotonin syndrome when you have too much of serotonin. Okay. Next, sir, a patient not responding to haloperidol and thioridazine is started on a drug causing hyperglycemia. Okay. Obesity, hypersalivation. Which drug was added? Okay. So they are asking, the patient is getting something. If the patient is not responding to this, resistant schizophrenia, we should call it as resistant schizophrenia. And the drug given for resistant schizophrenia is known as clozapine. And the other side effects are also given, by which you could have recognized this. Okay. Next, which is not used in the treatment of status epilepticus. Okay. The drug that is not used in status epilepticus is ethosuximide. It is only used for absence seizure. It is only used for absence seizure. Other drugs can be used. We already had an MCQ earlier. Levetiracetam, valproate, wide spectrum drugs, they can be used. There is a strong drug called fosphenytoin that can also be used. All right. Although the best drug is IV lorazepam. Okay. Next, you saw this schizophrenic patient coming with hypothermia. You must be bored of this. Now you know the question at the back of your hand. Okay. What is the treatment? What is the treatment? What do you do in this situation? See, you know that this all side effects are happening here. Remember, we'll be giving haloperidol along with, basically we'll stop the haloperidol, because haloperidol itself is causing the problem, na, NMS. And you will separately treat NMS by dantrolene. Bromocriptine can also be given in this, but dantrolene, is the thing that we'll be giving mainly. Okay. Match the toxins with their antidotes. I know you can easily match this on your own. Methanol ka antidote is fomepizole. Opioid का antidote is naloxone. Benzodiazepine का antidote is flumazenil. Arsenic का antidote is bal. They had given 4 options from which this matching type of options were given, so you had to choose that. Okay. Next, let's move on. A 7-year-old taking carbamazepine 800 mg daily develops imbalance and ataxia after taking erythromycin for 2 days. What is the cause? Okay, what is the cause? So you must remember, almost drugs we use in seizures, they cause something called ataxia when they become toxic. So this is nothing but carbamazepine toxicity. Now, why the word erythromycin is given here? Erythromycin is actually an enzyme inhibitor. Enzyme inhibitor means you have less enzymes to remove the drugs from the body. You are having less enzyme to remove the drugs from the body. So what is going to happen if you have less enzymes to remove the drugs? You will get toxicity. Enzyme inhibitors cause other drug toxicity. This is going to happen. Okay. Next, a depressed patient on imipramine is given diphenhydramine. Which relationship is correct? Okay, diphenhydramine. What is diphenhydramine? It is an antihistaminic. Imipramine is what? Imipramine is a TCA. So they are asking what is common in both of them. The answer will be they both block muscarinic receptor. Why? TCAs, if you remember, their side effect is they block HAM. Additional, they block histamine, they block alpha, they block muscarinic receptor. Antihistaminic, the first generation, they also block muscarinic. Remember, I told you because of blocking muscarinic, they also have additional antiemetic effect. So what is common in both of them? They both block muscarinic receptors. TCAs also do that. Antihistaminic also do that. Okay. So these are INI set questions. Obviously slightly upscale questions. Getting that? But if you read properly, it's not difficult. If you know your stuff, this also you can answer. Which drug acts on sodium channels by promoting slow sodium inactivation? So ladies and gentlemen, answer is lacosamide. This is the only slow sodium inactivator in this topic. All of them, they block fast sodium channel inactivators. Okay. So basically all of them are fast sodium inactivators. The only drug in this topic which is slow is lacosamide. Okay, lacosamide. Done. Again the same antidote type of a question. You can go through this. Time is there. Best answer this. Correct answer. The only one is this. Choose the correct. Benzodiazepine flumazenil. Many a times this antidote came, naloxone came, so you are now getting an idea क्या नहीं छोड़ना है. Next, despite all this, if you are still making mistakes in the repeat questions, then that's your blunder, my friends. Okay, one thing you must have realized, the way I've arranged these questions and everything, like for your revision, quick revision now, barely anywhere you will find it like this. FMG, NEET PG, INI set, nowhere, right? So we are doing this. I'm taking you like little upscale from FMG, NEET PG, INI set questions. So aram se you should be doing the questions in the real exam. Okay. Choose the correct statement regarding phenytoin toxicity and complications. Okay. So in this, we must remember acute overdose will cause cerebellar symptoms, ataxia. I told you this, it will cause ataxia. What are they asking? Correct statement. Correct statement is this. Why is the first statement wrong? Is it used in all seizures? Okay, is phenytoin used in all seizure? Obviously no. We don't use it in absence seizure. Okay, can't use in absence seizure. We can't use them in myoclonic seizures. All right. So it's not used in all seizure. It's a wrong statement. Complications are minimized if infused less than 250 milligram phenytoin units per minute. The answer is no. Okay. So this thing is actually for the drug called fosphenytoin, which is less than 150. Okay, this is, they're talking phenytoin. This is wrong. This is for fosphenytoin, that to 150 mg. That is also wrong. So these are little high level question. High dose leads to cardiotoxicity. Yes, cardiotoxicity is a side effect of phenytoin, and nephrotoxicity, it is not age related. Anybody can get it. It's not age specific. So basically, if you just know some basics, you can still rule out an answer. And don't think only you're feeling this is difficult. Even student taking INI set exam will also have to rule out an answer only. So don't feel bad. Oh my God, I'm not able to get it. Sir, same story. How much you know, examiner, they also know. So ruling out, you will answer this correctly. Next. So basically, there was an image that was given in the exam. They were asking GABA transporter inhibitor. Okay, GABA transporter inhibitor. So we need to remember T for transporter inhibitor. It is known as tigabine. How do I know this is a GABA drug? GABA in the name. T for transporter, transporter of this. Okay. The GABA, when it is released into the synapse, it is taken by this thing called GAT. What is GAT? GABA transporter. Okay, GABA transporter. So if you block this by the drug tigabine, GABA will increase in the synapse. Next, GABA can break down by one enzyme called GABA transaminase. GABA transaminase. So if you block this enzyme, again GABA can increase, and the drug that blocks this is called vigabatrin. GABA trin, transaminase inhibitor, vigabatrin. Okay, next if they ask something like this, you should be able to answer GABA transaminase inhibitor. Okay, next, if you see the question here, you must remember something. Cannabinoids are not approved in the treatment of. This is a difficult question. The answer is Rett syndrome. Rett syndrome में only drug approved is known as profenitide. Okay. The only drug approved in this situation is called profenitide. There is no other drug that can be used in Rett syndrome. That too, it's a very latest drug that has been approved. Very latest drugs will be asked in INI set. So correct answer will be this. That means other places cannabinoids can be used. Tuberous sclerosis, Lennox-Gastaut, Dravet syndrome, etc. We can use this. Okay. So with this, CNS also ends. Now, like this, we have the other chapters also, but I think it is quite late for us now. But still, you guys had hanged on to whatever we did so far. So I will see that when I find most likely tomorrow, if there is no other sessions lined up on this channel, I'll try to take up the other systems also. That is the part 2 as well. In the part 2, we'll get to do the CVS, endocrine, etc. Still, there are quite a lot of chapters remaining. Okay, sir. So all set to go. You guys go sit back today. Anyway, it was good to have all of you in the session. Hopefully, you guys got to revise decent amount of things in this session. So once this session is uploaded, I would like to see all of you guys in the comment box. As I told you, first, make sure you guys thank Dr. Bhanu, because I really appreciate what he's doing. So this is coming straight from the heart for that person. All right. So take care, everybody. And I'll see you in the part 2 session. It's just MCQs that are remaining. Okay. So I need to fill up those charts before I send you that PDF. So allot me some time. I've been having session after session already. I've had a session in the afternoon as well. Finish that and I'm with you guys right now. So even I am tired. Tomorrow morning also I've got a session at 9. So anyways, that's the reason last days are there. So pretty much packed up every day. You know, I was abroad just recently. I just returned 2 days back barely. And here I am with you guys. So because I was abroad, we were having issues of the setup. That is the reason I had to postpone this session once or twice. I was there almost 1 month. So away from the home as well. So anyway, now that we are here, ho gaya session, which I wanted mainly was the revision part. MCQs I'm doing as an add-on benefit so that you guys rock this exam. Okay, so God bless you all. See you tomorrow. Most likely, I have to ask. I'm not promising anything. I'll have to see when the date is available. Then I'll do the part 2 session. So when it is there, you will get a notification. So you can simply watch that. Subscribe to the channel of Bhanu sir. You will definitely get a notification. Okay. God bless you, everyone. Good night.